Everybody sitting and relaxed and grab your cup of coffee. Yeah. So hello, I'm Bernie. I'm the Assistant Director of Nursing for the Marie Keating Foundation. Sorry, I'm behind the little podium here, but if I move, maybe I can move a little bit. So you're all very welcome today. It's our 8th annual BRCA seminar. So we're delighted in the Marie Keating Foundation to be able to continue to bring this wonderful service to yourselves. We're going to have a fantastic day. All going well. We have a great lineup of speakers. So I have got a timekeeper here that's keeping an eye on me and is going to flash a little light if I don't be on time. So I'm just going to go through, before we get started and have our first wonderful speaker, I'm just going to go through a few little pointers. Primarily, I'm going to talk about housekeeping. So to start off with, if you wouldn't mind putting your phones on silence if you haven't done so already. And obviously, if you need to take a phone call, if you wouldn't mind stepping out, that'd be fantastic. Also, the other thing, next thing is the fire exits. We have fire exits all around the room, but ideally, this is the fire exit that we would all need to use right here behind the projector. There's double doors going out into the courtyard, okay? Toilets are right behind us, so just behind you, there's a little alcove to the right, female, male toilets right behind you, okay? So let me get to all the thank yous. So I had to write it all down, so hopefully I won't forget anybody. So first of all, a huge thank you to our sponsors. We have both AstraZeneca, MSD and HC21. And without our sponsors, we couldn't continue to provide such a fantastic free event for everybody. So thank you so much. We're so grateful. We know many of you are here today. Our speakers. So, of course, without the sponsors, the speakers, we wouldn't be able to provide a fantastic service like this. So we have a huge lineup of expert speakers who have taken time out of their busy days to be here today. And remember as well that we do have a Q&A session just before lunch. One or two speakers may not be able to stay, but we've got permission to email on questions to the speakers, so which is fantastic. Our BRCA peer support volunteers, we have 9 wonderful ladies who've trained up. I don't know why I should say trained, because they're trained with their life experiences to be BRCA peer support volunteers for our BRCA services in the Marie Keating Foundation. So we have 8 of our 9 wonderful peers here today. They will have badges on with their names, but can I ask if you have a question for our peers? We would prefer you to go through our website. There is on the mariekeating.ie website. You can go into BRCA services and submit a query rather than stopping them here today, because they're here, but we want them to enjoy the day as well. And we will have 2 of our peers up on the stage here at the end of the day. We'll have Jean and Magella in conversation with Carl Spillane talking about their experience of BRCA surgery. So thanks so much to our peers. Thanks so much to our own staff, to the Marie Keating Foundation. I think our CEO, Liz Yates, is probably tired of me asking for more and more and more. But thank you to Fiona there at the door. Fiona is our BRCA admin support. Thank you to Jane here beside us. Jane's behind the camera doing all the communications. There's Helen down there in the white, our Director of Nursing. Helen's helping us out here today as well. Anya, all our staff. Kathy over down here as well, pressing the buttons on the projector slide. Kathy is our Director of Communications and Public Affairs. Hope I haven't forgot any of our staff. Thank you to Springfield staff. Lisa, well, I did thank the peers. You're one of the peers. But Lisa is also one of our BRCA peers and working with us as well. So, and a huge thank you to all the Springfield staff. We've come back and forth. They've been amazing, especially Lynn Coffey. Thank you to all our stands down the side. Please do visit all the stands. I didn't get to speak to you yet, but I will come and speak to you all. I think it's really important during the break time. Go and have a look. These are all services very relative to BRCA and just fantastic. Oh my goodness, she's flashing the light already. I better keep on. Can I also say a huge thank you to Ginsec? Ginsec's provided you all with your wonderful goodie bags. So if you haven't got them already, you'll get them at reception or at the front desk from Fiona. Huge thank you to True Life as well, because running parallel today to the conference, we've got what's called a show and tell, and that's where 5 amazing ladies will show their breast reconstruction to others in private. That's going to be in the Sarsfield room later, and True Life have provided all the ladies with wonderful dressing gowns and goodie bags as well. So thank you so, so much. I think my time is up. So I'm going to introduce the first speaker. I think I bet my time, did I, Lisa? Ooh, I'm like a good racehorse. So I guess I should show you a lovely picture of all our panelist speakers here today. So fantastic lineup of speakers. Now, first up is Dr. Trina McCarthy. Trina is so fantastic. She keeps coming back to us again and again. Trina is a graduate from UCD and UCC, and she did her highest specialist training in Ireland and in Scotland, and is a fellow of the Royal College of Physicians Ireland, of the Faculty of Public Health Medicine in Ireland, and of the UK Faculty of Public Health. She works as a consultant in public health medicine with the HSE National Control Programme in the areas of health improvement and health services improvement, including hereditary cancer services. Trina, you're very welcome. We love having you back. I'm just going to switch presentations for a moment, so let's hope my tea behaves. Just get in here. Trina, we've got you here. Now, handing over to Trina.
Thanks, Bernie, and thanks for the invitation here. Bernie was very kind and didn't let you know that I sent in the wrong slides. So these are now the right ones. Hopefully I won't be getting any surprises as I go through them. So as Bernie said, I work with the NCCP, the National Cancer Control Programme, part of the HSE around planning services. So we've had a model of care, which I suppose includes a vision for what we want the services to be. And for those of you who've been here before, I suppose I've shared some of that with you, but I just really want to let you know where we are now and how things are moving along. So obviously cancer predisposition, hereditary cancer would have been highlighted in our own cancer strategy, but then also there's a genetics and genomics strategy that came out at the end of 2022 and a genetics and genomics office set up. So I just want to mention them in terms of they're doing some work, I suppose, looking at the broader genetic service and looking at things such as access to genetic testing, how we look after tests that are going out of the country and streamline those services, and also developing the workforce. So genetic counsellors as a really key part of the staff in Ireland and how we grow that workforce and attract more people to the specialty and develop that. So there are a couple of things, I suppose, in this space that they have been progressing as well. But as I said, what I'm giving you an update on today is the model of care specifically for cancer predisposition, including BRCA, and where we're at this stage. So I won't read through all of these, but obviously we have a clear vision that a lot of people in this room as well inputted to in terms of how we would like hereditary cancer services to work. And, we know there's still a lot of challenges right across the pathway, but we have an idea of where we want to get to, and the movement might be slow, but we're working away at it and trying to get as close as we can. So in terms of the overarching structure, I suppose this year in particular, we're again trying to move towards, well, you want to have your generalist services. So that's not just your GP and your community services, but also your general, say, breast services or gastro services, or, the hospital teams that don't work in genetics, putting in clear pathways for them. So if they come across somebody that needs testing or counselling, that they know where to refer to. Trying to put a structure in then in the regions so that you have some specialists within your regions, that it's not all just in Dublin, I suppose in particular, that you have specialist knowledge growing within your area, and again, pathways to increase what we call mainstream testing and getting cancer teams to do a lot of the testing and the pre-test counselling. So that's what the kind of middle yellowy one is there. But with the bubble there, which is the outreach, so again, trying to put genetic counselling resource into regions. So again, it's been a really big challenge in terms of having enough genetic counsellors for the country and having people wherever you are having access to that services. So I'll touch on that again later. Then having the specialist services nationally supporting issues around, say, some complex decisions or interpretations of tests or advice, and also, being able to support those regional teams as well. So within your own regional service, this is just from the model of care, just lots of different teams can be involved. Say in BRCA, it might be a breast team or a gynecology team that you were involved with, or obviously medical oncology if you needed cancer treatment. But that we put a core there in the far right that have genetics expertise, so have genetic counsellors reaching in or based in the regions, having resource associates who'd be looking at the tracking of patients and making sure it's a smoother journey, and admin support. And along the bottom, there are a lot of support diagnostic services that have been really challenged, or having psycho-oncology services, looking at developing those services as well for people with a cancer predisposition, not just a cancer diagnosis. So I'll touch very quickly on the implementation areas of the model of care and let you know where we're at. The top one in terms of the oversight for implementation, we have the Hereditary Cancer Steering Group set up with some excellent representation from here on that group as well. And then I'll just touch on where we're at along some of the others. So the workforce, I've mentioned already as really being, I suppose, from your own journeys, I'm sure that the people you meet and the expertise of the people that you link in with is just so critical. In this year, in the service plan, so in the HSE, it has to be kind of, you have to apply for everything and ask and work with the post you get every year. But this year we have additional genetic counsellors coming into the service, one for the cancer specialist genetic service centrally, and then also it'll be our first one where we're putting somebody into a region. So it'll be really interesting to see how we can make that work and have one of the regions with a cancer genetic counsellor actually within their local cancer centre. We're putting in the genetic resource associates, which are those admin resources to support the pathways, and then advanced nurse practitioners in specialist areas. We've seen this work really, really well, particularly in breast and for patients with BRCA, but also looking across other areas such as colorectal for Lynch syndrome, and gynae for both Lynch and BRCA and other areas. So then also medical oncologists with a special interest, that's another one. The network and the national MDT I've mentioned already, but I just want to highlight that even if you put staff in, you also need the necessary supports. Like one big thing that we've come across is theatre access for people getting prophylactic surgery. So in terms of one of the areas, we've managed to get funding where they're able to use get access to theatre and funding to staff that. So it's not just the specialist, sometimes it's actually having the space to work. So and there will be other specialist roles for future development, as I mentioned, such as psycho-oncology I mentioned earlier. I think you had a very good presentation about 2 years ago from James's, and I know there's some research was done in Vincent's Hospital recently. So I think we really want to look at what psychological supports, again, is it specifically for people with cancer predisposition, whether you've had a cancer diagnosis yet or not, that it's it is a specialist area, and it's something that we need to look at how we support and grow that service. The cancer genetic counsellor that I mentioned, this will be the first time where we'll have someone in the regional services, and it'll also, this would be important for we're going to have non-geneticists, so people within general cancer teams are going to be more and more involved in doing pre-test counselling, and this is really about getting people their BRCA tests quicker, that they'll have act more rather than having to wait for a genetic counsellor appointment, so that they can have that pre-test counselling done by their team. But obviously they need to be supported and trained in doing that, so having their genetic counsellor as a go-to person will be great, and that they'll also support the education that's needed around that, and also be an option for if somebody says, well, actually I really want to talk to a genetic counsellor before my test, that should always still be available as an option. And then having had your diagnosis, very important to have genetic counselling available, and that they'll be the link then as well to as kind of a national specialist service, and where people's cases need discussed, that they would be the expert bringing that to get input from others if needs be. So there's a lot of education and training that's been going on. A lot of our advanced nurse practitioners have done the RCPI certificate in cancer genetics, which was not an easy task, they've told me. They've organised a cancer genetics nursing conference the past couple of years, which has been great. And then in terms of accessible kind of testing for the general cancer teams, we have HSE Land, which is sort of the e-learning place that we have a number of modules. There's one from the Genetics and Genomics Service to try and upskill everybody on what genetics is, but then also for your cancer teams to have modules that they can do, shorter, more accessible modules, that they don't have to be released from work for, lots of days to do this, but that they can do some e-learning on these topics. And the first two ones in terms of cancer genetics and getting informed consent, those are all, they're almost ready for release now. So it's really good to see that we'll be able to get the general workforce upskilled in this area, and then we'll have a BRCA and Lynch syndrome module coming with just a bit more detail as well. On clinical guidance, what I mentioned around your mainstream testing by your cancer teams, I suppose that's one of the first things that we're really trying to support, and having a test directory is a piece of work that's been done by the Genetics and Genomics Office, so that there would be a test directory with what genetic tests you should do in what situation, and that would just not cover just cancer, but everything, lots of different specialist areas. And that means that, again, wherever you are in Ireland, that you're getting the appropriate test for your own clinical situation. And we have the cancer chapter is very much almost finished in that. So that, as I said, will support all the other teams around the country who are going to start doing this. And we've also worked on a consent form, or sort of a record of discussion, which would prompt what should happen in that pre-test counselling. So again, thanks to everyone who's inputted from the patient input as well, in terms of what would be appropriate to make sure is covered when you're having that discussion with your cancer team, and just to support you, I suppose, in having you're making that decision to have a genetic test in the first place. There are two other pieces I'll just mention. One is a testing guidance in terms of testing tumour tissue around identifying Lynch syndrome, which is a different cancer predisposition. And then also there's tumour testing guidance and a national directory on that. And that is a lot more around if people have had a cancer diagnosis, you might have been told there was a genetic test on your tumour, and that's often to look at what treatment, what drug treatment in particular might be best for you, but also things like prognosis and that as well. So that guidance has been developed as well. So that's also up. On patient information, I have to start by saying that one of the reasons we haven't started with BRCA patient information as a priority is because there is such a good resource in Mary Keating, and with the peer support networks, and there was actually such availability of resources there. So from a patient information perspective, it was really Lynch syndrome was highlighted as the area that had that gap, didn't have the same available information. So things like patient information leaflets for Lynch syndrome, they'll be available on healthpromotion.ie, or having on the HSE app just accessible information about Lynch syndrome. And a request that has been raised has been around having a patient passport, which has been done for people with a diagnosis of colorectal cancer, but would something like that be useful? So it might be worth thinking about from a BRCA perspective, if something like that would be useful in terms of tracking your appointments. And then the last area to mention is population data and patient registries, and we've had sort of just our initial workshop on that very recently, to which some of our patients came, with much appreciated. And it's really to start looking at, well, there are clinical uses for patient information and things that your own teams need, in terms of managing your care, but can we do that in a structured way? And, are there systems that would help that work well? But then also, what kind of data at a national level is useful to help us plan services, make sure we have enough MRIs or enough preventative surgery facilities, and also to help us do things like audits and research. And I think, where we agree those measures, and this is something which is just kicking off, we'll probably be looking for some volunteers. We're always looking for volunteers in these groups. I think it's really important that we link it with what the right clinical pathways are, and make sure that if we're measuring things, that they're meaningful measures to patients. That's a really important thing for us. So I'll just stop with just our vision again, in terms of what these are the areas that we're moving towards meeting. And unlike Bernie, I didn't make a list of thank yous because I knew even if I made a list, I'd forget people. But I would just like to thank Bernie and the peer support workers in terms of their input to this work. I think is just absolutely invaluable. I know it's one email to Bernie and she's like, I'll have 2 people for you tomorrow, and so I'm saying thank you both for all of the input to date, but also the future work, because, I'll keep coming and asking, and thanks very much for your attention today as well.
Thank you so much, Trina. Yeah, we're in this together. Yeah. Right, I'm just going to switch slides here now. Thank you so much. And any questions for Trina, if you can hang on to them, and around 20 to 1, we'll have a Q&A time. So let's just get back here. We'll just switch back, Michael. Okay. Hopefully we have wonderful Michael up here on the screen, and we have. So for this presentation, we will be able to get it up on the projector as well. So you'll be able to see here at the front, and we'll have Michael's up in the projector as well. So come over here beside me, Michael. I don't bite. So Michael Farrell, here beside me, is a registered general nurse, and he has worked full-time in clinical cancer genetics for over 20 years, and is an accredited clinical nurse specialist in cancer genetic department of the Mater Private Hospital, working with Professor David Gallagher. Prior to this, he worked as a research nurse in cancer genetics in St. James's Hospital with Professor Peter Daly, where he developed a research interest in Lynch syndrome and completed his master's in molecular medicine through TCD. Michael has given lots of presentations both at national and international level, and he has delivered grand rounds in St. Vincent's University Hospital, and has presented talks on various aspects of inherited predisposition to cancer healthcare. God, Michael, you've done too much. I can't keep up here. 5 minutes or call. Michael has also presented at previous BRCA conferences, and I think you can all see the fantastic work Michael does and continues to do. He's an author in 2 papers published in Journal of Familial Cancer, and is co-author in a further 20 papers. And I think, Michael, I could talk forever, but I think we better let you do the talking. So over and out, and I think we'll get Michael as well on the middle screen. Thank you so much. Chair as well, if you want.
That's great. Thanks very much, Bernie, and to the Keating Foundation, being wonderful ambassadors for patients and their families. But I'll start off. I was at a conference a few years ago, and a geneticist, Mark Robson from Memorial Sloan Kettering, said it's always good to start off with a clinical case. So we were referred the arrow point to this woman here. So this is a pedigree or family tree. So this woman, the proband, triple negative breast cancer, 60. And then you see she has one sister here, breast cancer, 71, and one brother who had a cholangiocarcinoma at 60. And then the only other 2 cancers here are on her. That's her father, who died at 73, no cancer. And she has 2 first cousins on her father's side who have both had breast cancer. So she was referred in to see us because she didn't quite meet criteria for testing in the public system. So we know it's only 10% at most of all cancer is hereditary. The majority of it is not. Now, there is as you can see here on this pie chart on the left-hand side, with common cancer like breast cancer, colon cancer, prostate cancer, common diseases, large families, the odds are good that you will see a clustering by chance alone. But in effect, it's only 5 to 10% of most of it is hereditary. Again, but there's 10% of all ovarian cancer is hereditary. But in terms of a brief history, Paul BRCA in 1866 was the first scientist, I suppose we think, that published on hereditary predisposition to breast cancer. Now, he's a French neuroanatomist. And the reason he came out of his area of expertise is that he published a paper with 10 cases of breast cancer over 4 generations, but one of them happened to be his wife. On the right, Henry Lynch, and Caitríona and Dr. McCarthy mentioned Lynch. He had Lynch syndrome. He made the observation in the 1970s that women, if they tended to have a hereditary predisposition to breast cancer, they also had high lifetime risks of ovarian cancer. So he was the first one to make that observation in the late 1970s. And then on the left, Mary Claire King and her group in 1990, they identified where in the genome, on chromosome 17, the BRCA1 gene was located. That was in 1990. And it took another 4 years for that gene to be sequenced, for the scientists to know where its function, basically, where it began and ended, and the actual sequence of the gene. And then this is Professor Peter Daly. I was lucky. I was in the right place at the right time, and I was working with Professor John Kennedy in clinical trials in St. James's, and Professor Daly asked me whether I'd come and work with him. So instinctively, I knew it was the right thing to do, even though I knew what I was letting myself in for. But on the left there is a paper from 1995, which demonstrated the identification of the BRCA2 gene, and in conjunction with other colleagues like Will Morris and Ross McManus from St. James's. Now, and this is the 186 family. Now, there is a bias when you're looking at family trees. Now, because I was talking to my colleague Roisin Clark a couple of days ago about this, you know, I know that you can't see it clearly, but like there's 1, 2, 3, 4, 5 sisters here with breast cancer. Now, if you're a BRCA carrier, you're looking at this family tree, you're thinking, jeepers, if I carry a gene, I'll definitely get cancer. But there is a bias here, and as remarkable as it was for that group and others to identify where the BRCA2 gene was located in 1995. Another benefit of identifying mutations is that, as well as giving you a marker for risk, for other family members, when they arrive in, you have a copy of a family tree. So you don't have to keep reinventing the wheel every time a family member comes in. You just print out a copy of the family tree, the pedigree. But this family was so large that we were sellotaping A4 pages together. And this is no word of an exaggeration. The family was so large, it was like a roll of carpet, you know, because they had very large families, and then it got very complex because you had 2 sisters from a large branch of the family, married 2 brothers from another large branch. So whenever a member of the 186 family was come in, you just roll out the carpet, find the section you need, photocopy it, and there you go. But so when you look at that gene, that family tree, there are plenty of people in that family who carried the 186 mutations, we call them, never got cancer. In terms of how common is it, maybe 1 in 400 people off the street carries a BRCA1 or 2 mutation. 10% of women with breast cancer, less than 40. And it's just interesting. Now, I know I work in the matter private, but when I mentioned the POSH study, it's not because of that. I like this study clinically, because it's fairly recent. So you see there, 2018, Diana Eccles group in Southampton, and they had 2,733 women who had breast cancer at 40 or younger. They didn't talk about family history, just said, well, let's look at that cohort and how many BRCA1 or 2 mutations we identify, and you see here, 12%. So in keeping with the 10% I mentioned earlier from the pie chart. Now, when they looked of that 2,733 women, 20% had a triple negative breast cancer. So when they looked at that particular group, the mutation detection rate jumped to 24%. So clinically, I like that study. You know, when women come into us who have newly diagnosed with breast cancer, if it's estrogen positive less than 40 and they don't have a strong family history, you'd say you've got a 12% chance of being positive. And similarly, if it's triple negative, less than 40, no significant family history, your probability is about 24%. And you can see women who carry a BRCA1 or 2 mutations have high risk of other breast cancers. So that is, and Dr. McCarthy hinted at it there in our talk, that is having an impact on the service, because more younger women diagnosed with breast cancer are being put on what's called neoadjuvant chemotherapy. So they have the chemotherapy first and then have their surgery. So the knowledge of the BRCA status after their chemotherapy is finished, before the surgery, is very advantageous, because if a woman carries a BRCA1 or 2 mutation with a higher lifetime risk of another breast cancer, then usually their surgeon would have a discussion about the pros and cons of risk-reducing bilateral mastectomy. Interesting as well about that POSH study is that there was no overall difference in outcome. So carrying a BRCA1 or 2 mutation didn't impact the outcome, because there is that fear that if an individual has a cancer and is a BRCA1 or 2 positive, that makes prognosis worse. Well, I don't think there's any evidence for that. What's the difference between both? Well, BRCA1 carries higher risk of breast and ovarian cancer than BRCA2, but ultimately, the care for a woman, if she carries a BRCA1 or 2 mutation, is the same. Now, if you don't mind, I'll just jump forward. Yes, this slide, I suppose it's the basis of the work we do. Honestly, I could talk for about half an hour on this slide. It's based on Al Knudsen, a pediatrician in the late 1960s, and he decided to go into research. And he looked at retinoblastoma, a tumor of the eye that primarily, almost exclusively affects children. Like, there's only about 5 cases diagnosed in Ireland every year. So this brilliant physician, you know, I suppose you have to be brilliant, but you also have to be lucky, you know, because when he went into research, he was very lucky in that he met a pediatrician from America and an ophthalmologist from the United Kingdom, and they had kept records of all the cases they ever came across of retinoblastoma in their careers. So now you have brilliance, but you have large data sets, you know. So he quickly observed that there was a couple of things. One, the retinoblastoma tended to run in families, or it didn't. And if it ran in families, it tended to present earlier. God help us, it tended to present within the first, say, 3 to 6 months of a child being born, and it tended to affect both eyes. So those are the principles that which we look at. When we're looking at family trees, you're looking for a pattern. You're looking for early onset cancers, bilateral, both sides, both eyes, both breasts. And then you're looking for uncommon cancers like ovarian cancer, pancreatic cancer, male breast cancer, because you tend to see a pattern in the wider family. So in this cartoon, so as men are squares. So this woman has 2 normal copies. You know, so can you see the mouse on that? And I just walk over here. Two purple boxes.
Not sure if it's flick. I think it connects more with the projector than.
But see, on the right hand, on say your right hand side, those 2 vertical lines, those 2 purple boxes, they may represent, say, a BRCA1 gene. It could be a Lynch gene, but say it's BRCA1. This woman and her partner carries 1 copy of mutation, and the other one is a normal copy. So they're tumor suppressor genes. They're like brakes of a car. They have a daughter. Now, she can only inherit a normal copy from mum, because mum only has normal copies. But she has an equal 50-50 chance of inheriting the normal copy. But in this case, she inherits the copy of the mutation from her father. So, but like I said, they come in pairs. I suppose Mother Nature is kind to us. Now, we run into problems. So for whatever reason, the normal copy of the gene is knocked out, and you've that second hit. Now, when I was putting my slides together, I was thinking this morning, one criticism you could make of it is that I don't mention the men here, but the men are as important. Women who carry BRCA1 or 2 genes, they have high lifetime risks of breast and ovarian cancer. But 40% of women will carry breast cancer genes, won't get cancer. For men, the population risk of prostate cancer is 8%. A man with a BRCA2 mutation, his lifetime risk is about 24%. So he's got 3 times the population risk. He's still more likely than not to get it. But of course, he could also pass on the risk to his children. And a man has about a 6 to 9% risk of breast cancer. Because I remember a few years ago, a GP rang me about one of our patients who was a BRCA carrier. And then when we had our discussion about her patient, almost as an aside, she said, you know, interesting enough, she said, there's a BRCA gene in my family, but it's okay, it's on my father's side. And of course, I said, no, they are as important. It has to be looked at, you know. The criteria for diagnostic testing, I'll fly through it. Genetic testing is expensive, it's time consuming, so you can't test everybody. Even though the cost is decreasing, certainly. So the Manchester scoring system was the criteria that we would use to see, well, how likely is it that you're going to find a mutation? So it's based on family history. So on the top of the chart here, a woman with a breast cancer less than 30 gets a score of 6 and 5. And as the age of diagnosis decrease or gets older, the score decreases, but there are some heavy hitters like ovarian cancer and male breast cancer. So long story short, if you draw the family tree, if you generate a Manchester score of 16, it equates to about a 10% chance of identifying a mutation. So obviously the higher the Manchester score, the more likely it is you're going to find a mutation. And back to the case we mentioned at the outset, there's 3 outcomes from a diagnostic test. There's 2 types. We either identify a mutation, the majority come back negative. In many ways, the 3rd outcome is probably the worst case scenario. You get what's called a genetic variant of uncertain significance. In other words, the lab say, look, there's a difference on one of the BRCA genes, and they say, look, we don't know, did it cause your cancer and made any contribution to family history, or is it a red herring? Is it what we say a polymorphism? And a polymorphism is a fancy way of saying, listen, grab the next 100 people at the coffee shop and the bus stop, do this genetic test. You'll find a number of people have the very same polymorphism, but they don't have a family history of anything, you know. So again, these are the patterns we're looking for. We're also interested in ethnicity. We know 1 in 40 people of Ashkenazi Jewish heritage carries one of the 3 Ashkenazi Jewish founder mutations. And the benefit of finding a mutation is that, to use a phrase of Professor Gallagher's, you have a marker for risk. So you can see, well, who in the family shares it? Goes back to Alec Knutson's cartoon. If you identify a mutation, you know that gene, it's either coming from the person's father or mother. Siblings have a 1 in 2 chance of sharing it. Children have a 1 in 2 chance of inheriting it. This is a case from a good few years ago of 2 sisters who had breast cancer, identified a BRCA mutation. So initially, when we looked at the family tree, we said, well, okay, it's not coming from both sides. So given that there was 1 paternal first cousin with breast cancer at 40, we tested dad first, but he was negative, when actually, in fact, the mother was a carrier, and there she is, she's probably coming on nearly 90 years of age now, carried the BRCA2 gene, doesn't have cancer. So that's important for us to say to patients, carrying a BRCA gene, developing cancer are not the same thing. Back to this woman went for genetic testing and carried the BRCA2 mutation. So she was very upset by the news because she hadn't qualified for testing initially. She was of the opinion that, and to be fair, I probably said it to herself. I said, look at the probabilities, it'll be negative. But anyway, she carried a BRCA2 mutation. So it was Professor Seamus O'Reilly from Cork who referred her to us, and I presented the case I was down in COH doing a presentation, and I presented this case, and actually Professor O'Reilly did say that after that diagnosis, he referred this lady for a risk-reducing bilateral salping oophorectomy, and they found a fallopian tube tumor. So for her, it was a good outcome. And then, of course, we know then her daughters and her son have a 1 in 2 chance of inheriting it. Siblings have a 1 in 2 chance of sharing it. So it gives us a marker for risk for the wider family. And oophorectomy is associated with prevention, and that's what information allows us to do. The results of genetic testing, it's empowering knowledge. So if there's a mutation there, the benefit of it is that it can clarify individual risks, but there's benefits and there's risks. Particularly, I mean, it's well described in cancer genetics, is that if you test siblings, if you test sisters for, say, a BRCA gene, if one is a carrier and one is negative, in many cases, particularly in close-knit families, the sister who is unaffected can be more upset than her sister who is a carrier. There's this concept of survivor guilt, even though none of us have any control over the hand of cards we were dealt. Reasons, I mean, the reasons that the family history may not be as relevant is the 1 in 6 family was the exception because it was huge. You know, the patterns were easily recognized, but the family sizes now are increasingly smaller. So it's getting much harder to see a pattern in these much smaller families. The barriers, again, some fear that maybe BRCA status worsens the prognosis. A common one is discrimination, and certainly we know the Disabilities Act of 2005 prohibits employers and health insurance companies from asking about genetic testing. Myself and my wife met a mortgage broker 5 years ago. He asked us a list of questions, the length of your arm. The only question they could be asked is, did any family member first degree, so that my parents or siblings, did any of them have cancer less than 60? That's all an individual can be asked. There is a fear of the stigmatization, fear of the preventative surgery. Certainly more more younger women do elect to consider bilateral risk-reducing mastectomies. Now, the evidence is that the high-risk screening is as effective as the risk-reducing surgery. So there's no overall difference in outcome, but there are differences nonetheless. And even an early screen-detected breast cancer with a very good outcome, very good prognosis, would have to be treated with the very least surgery and possibly chemotherapy and radiotherapy. So for some women, considering having the risk-reducing surgery reduces the chance of that happening as much as possible. But as I said, it's a personal decision. The only strong advice currently is that women consider having their ovaries removed when they're finished family, because ovarian screening, as of course it stands, is not effective. Testing children, usually about once a year, I get a call from it's typically a man, he's in his 50s, he carries a BRCA2 gene, he has girls at home 7 or 8 years of age, and he would do anything for us to test them. But when you explain, look, if we test your daughters, we're not going to do anything till at least 25 in terms of an intervention or a screening. And of course, if you test your children now, your daughters now, you take away their autonomy to make their own decisions when they're older. Interestingly, there is a difference in risks, and we take this in mind. It's a common question in that clinically we meet women regularly from BRCA families. These women, they're in their 70s and 80s, and it's typically their sisters were found to carry a BRCA2 gene, BRCA1 or BRCA2 gene about 20 years ago, and the only reason they're coming now is their children, typically their daughters, are coming up to their 40s, and they come in to see Professor Gallagher and I and say, I just want to rule this for my children. But many of the time, I'm ringing these women in their 70s and 80s and say, you better sit down because you carried the BRCA1 or 2 mutation. So there is a difference in this top slide from Mary Care Kling's group, is that women born before 1940 have lower risk than women born after 1940. So there's been, this question keeps coming up in clinic, what's protecting these women? And the last time I spoke at the Marie Keating Foundation, Sarah McGarrigle from St. James's presented her research there, and BRCA mutation carriers are heavier now than in previous generations, but actually, I think we're all heavier. I mean, I don't know, when I spoke for the Marie Keating Foundation, it was about 6 years ago, I'm definitely heavier than I was then. So I think as a population, we're heavier, but weight seems to be a risk factor. And this is, Sarah's research it kind of influenced my thinking, in that in my clinic, when I would meet girls, say 18, 19 years of age, I would typically say, look, you're entitled, if there's a BRCA gene in the family, you're entitled to test from 18. We won't be doing any screening until 25. So I did say, now if they wanted to test, I would of course provide it, but I would say, look, we're not going to do anything until 25. So if you want to do your traveling, your study, and then come back and near the time, and then we can test. But the evidence is that weight reduction reduces risk for BRCA carriers. Exercise protects women, and sporting activity protects women. So now I'm on the mindset, well, look, if you carry a BRCA gene, that knowledge, you can, in your early 20s, you can protect yourself potentially based on the studies that have been completed so far. I'll just fly through. These are Sarah McGarrigle's slides, who's very grateful to let me show. But in effect, physical activity, exercise is protective, and particularly for women who are younger. The earlier you start the exercise, the I suppose near normal BMI you can have, the more protection it confers. As I said previously, women who carry breast cancer genes have much higher risk of other breast cancers, so it is impacting on care, in that more women are electing to consider bilateral risk-inducing mastectomies as opposed to screening, but this is a personal decision. Another area that's impacting the service is that we know patients with BRCA mutations can benefit from targeted therapies called PARP inhibitors. Now, that's the molecular slide, which I'll jump over briefly. I'm not going to go into the minutiae of that in the clinic, but this again from Seamus O'Reilly, the way the PARP works, it's a very clever mechanism, is that it's a way of, if you can imagine a BRCA cell as a cell with a stool with three legs on it, but the PARP is able to target the pathway. So as is to knock out that third leg of the stool. So it's a very clever way of targeting a cancer cell. And again, that is impacting our services, that we're getting more referrals from clinicians who have patients who have got maybe metastatic disease. And the question is, well, if they carry a BRCA mutation, well, then they can benefit from a potential PARP inhibitor. I'll leave on this final slide. Very interesting. When I worked with Professor Gallagher, we were years referring women for gynecology screening because that was something. About 6 or 7 years ago, there were a number of case reports of women who carried breast cancer genes completely well, asymptomatic, went to have their ovaries removed, and there were a few case reports of women having fallopian tube tumors identified. So now there is a thinking that actually it may not be the ovaries that are at risk, it may be in the fallopian tube. So there are studies, and this is kind of initial investigation in the Netherlands, of women who carried breast cancer genes. When they're finished familying, they're having bilateral salpingectomies. So, and then they're probably coming back and having their ovaries removed near their 50s. So it'd be very interesting to see what the long-term outcome of that, from that research is. So I think it's optimistic, or it's hopeful for the future, that hopefully we will be wiser as we learn more. And on that note, I'll finish up. Thank you very much for the invitation, and I'll be happy to take any questions later.
Thanks so much to Michael. Fantastic presentation. And Michael will take questions at about 20 to 1 during the Q&A session. So thank you so much. And next up is Dr. Ahmed Omar. Dr. Ahmed, I hope I'm pronouncing your name. Yeah. Omar is Medical Director of the Beacon Care Fertility and is recognized globally as a leading expert in reproductive medicine with over 30 years of experience throughout Ireland and Europe. As Medical Director at Beacon Care Fertility, is known for his evidence-based approach and commitment to personalized patient care. A graduate of, I hope I pronounced this one right, Ain Shams, University Cairo. He has been a member of the Royal College of Obstetricians and Gynecologists since 1998 and is also affiliated with the Royal Society of Medicine Ireland and the British Fertility Society. I'm really tongue twisted today. Missed the coffee. His specialist interests include, which is what he's going to talk about today, pre-implantation genetic testing, also known as PGT, recurrent implantation failure, and reproductive immunology. So without further ado, going to hand you over to Dr. Omar. Yeah.
Thank you very much, and thank you, Bernie, for the kind. Maybe move it up. And thank you very much for the kind presentation. Very glad to be here, and actually very educational so far. So I'm really happy and honored to be here. I joined Beacon Care Fertility, which is an IVF clinic with special interest in genetic testing, in 2014. The clinic itself was established maybe about a year before that, and the aim of establishing the clinic at the time was to provide genetic testing in Ireland, because before that there was no service of providing pre-implantation genetic testing in Ireland, and most of our Irish patients would have had to travel to other countries to do something like pre-implantation genetic testing. More commonly was England, really, where they traveled. So things have changed a lot since then. So what is PGT? Or PGT is an abbreviation for pre-implantation genetic testing. And pre-implantation genetic testing, or PGT, is a technique that is used to test embryos that have been created by IVF for inherited genetic condition, or as we call them, mutation. I mean, among them is BRCA1 and BRCA2 genes, but also there's many, many genes that can be tested with pre-implantation genetic testing. The aim of the treatment itself is to exclude embryos that are at risk before pregnancy and use the embryos that are not at risk. Why is it important for BRCA gene carriers? First of all, I'm sure you're all aware BRCA gene is a dominant genetic condition, which means the child have to inherit one gene to be at risk. So if you're a carrier of BRCA1 or BRCA2 gene, PGT can reduce the risk of passing the gene to your children. Now, it's not the only reproductive option. There is other reproductive options. One of reproductive options, I mean, there is one of the options is to test during a pregnancy, which we call prenatal testing. And there's two types of prenatal testing that can be offered. One is CVS, or chorionic villus sample, which is basically taking a small sample from the placenta or the afterbirth at around 11 weeks of the pregnancy and testing them for genetic condition in general, or a test that can be done a little bit later called amniocentesis, taking a little bit of fluid from around the baby at around 15 weeks and testing for a genetic condition. Now, these two procedures are not without risk. I mean, the risk is about maybe 0.5 to 1% risk of miscarriage, but also there is a dilemma of what to do if there is a positive diagnosis as that. And that's not only specifically for BRCA gene, maybe as well there's other condition that can be quite an important decision regarding termination, or even to continue with the pregnancy, knowing that there is an issue with this pregnancy, which can be a serious medical condition. So this is part of the dilemma that really with prenatal testing. The other option, obviously, which we're going to be talking about today, is the pre-implantation genetic testing, which is becoming now more and more really popular or commonly used for genetic condition in general. And then there is other option as well, the use of donor sperm or donor egg, or we call them donor gamete. That is also an option if the patient or the couple does not want to go through fertility treatment because of these risks, or adoption, that's another option, or even in some cases to decide not to pursue parenthood or not to have children. Now, all these options are normally discussed before the patient is being referred for the pre-implantation genetic testing. And if the decision to do pre-implantation genetic testing, then she or he is referred to the IVF clinic for this procedure. So the first step is the referral for PGT or pre-implantation genetic testing. The referral can be either done through, which the most common type of referral, through the geneticist or the genetic doctor or the genetic counselor. And in this case, the patient would meet the genetic counselor or the geneticist and discuss the condition, risk of inheritance, the reproductive options that we spoke about. And then if the choice is to do pre-implantation genetic testing or PGT, then the geneticist or the genetic counselor will be referring the patient to the clinic. But also referral can be done self-referral, so the patient can refer herself to the clinic or through the GP. And in this case, we just need the report or the test that has been done to prove that there is a genetic condition. And then we can refer the patient to a genetic counselor or to the geneticist after that. But it's very important before any treatment that the patient see or speak to the genetic counselor or the geneticist. So as we said, there is a pathway normally for patients that are doing PGT. That pathway starts with the referral, okay, which we spoke about. And once the referral is done, the patient would be seen in the IVF clinic to meet the doctor. And in a clinic like ours, we have a genetic team. And that genetic team is formed from a consultant, a genetic nurse, a genetic admin, and a genetic counselor. And once the patient see the doctor, then the discussion is normally about IVF, how the process is done, chances of success, how long does it take. So all investigations, there's fertility investigations that are going to need to be done. So all that will be discussed on the consultation itself. And if the patient is agreeable to go through treatment, then the clinic will get in touch with the genetic lab that does the test of the embryo to create the test for the genetic testing. Now, genetic tests are not really one fit all, but they are tailored. So it's a very important step, and I'll talk a little bit more in detail about that. So that's an important part of that pathway to treatment. Once the genetic test has been completed or designed by the genetic clinic, then we can move to the next step, which is the patient is back again to the IVF clinic to start the process of treatment. By that stage, you would have had the investigations, fertility investigations, and that would be discussed, and the plan of the IVF treatment with PGT would be finalized, and then proceed to treatment. Now, I'm just going to talk a little bit about the genetic test, because this is an important part, really, of the treatment itself. It's a step we call development of the test and optimization of the test, and that is done by the genetic lab that is going to perform testing of the embryo itself. That process takes about 4 to 6 weeks. Normally, during that process, the patient gets a call from the counselor that works, the genetic counselor that works with the lab, to get cheek swabs. He'd be asked for cheek swabs in order to be able to provide DNA. And that's not only from the patient, but also from members of the family. Sometimes the parents would be required to provide these cheek swabs. And the idea is to get DNA to be able to design a specific test for that specific family. And that's what I'm saying is that these tests are tailored to improve their chance of diagnosis itself. They're more accurate this way. Once that test is developed, then the treatment process can start. Now, we go just back to the fertility investigation, and that's done before any IVF treatment. So they're very basic tests, really. For the man, you'd be asked for a semen analysis just to check that the sperm quality is fine. For the female partner, then we ask for a blood test called AMH, which is a hormone that tells us about the ovarian reserve or the egg count. And it's a blood test that can be done at any stage, and it's pretty accurate in looking at the ovarian reserve. The other test is an ultrasound scan, a gynae ultrasound scan, which is a scan just to check that everything is okay in the pelvis. And we also do something called antral follicle count, which is count the number of little follicles. And follicles are little spaces in the ovary that contain the eggs. And that also can help us to know the reserve before starting the treatment. Now, this is just an image of the, I'm just going to move over here, of the ovary. Looks like an almond shape there. And the little black dots there that you can see on the ovary are these spaces, which we call follicles, that the eggs are in. And the more follicles that we can see on a scan, the more count or the more the eggs that are stored in the ovary. So it's another way of knowing the ovarian reserve. Now, the next step is the IVF process itself. An IVF process, we can divide it into 4 stages, really. The first stage is to stimulate the ovary to produce the eggs. And that is done by a hormone in form of, like an injection that you take daily. It's a bit like if you have seen an diabetic pen, the EpiPen. It's very similar to it, very easy to use under the skin. And it's taken for about maybe 10 to 12 days starting from the second day of the period. 2 scans are required just to monitor how these eggs are growing and developing in the ovary. And once the egg's size is fine and we're happy with that on the final scan, which is normally about day 10 or day 12, then the next step is to collect the eggs. And this is a very minor surgical procedure, a day procedure, require anesthetic. Takes only about 20 minutes, and you're able to go home within 1 to 2 hours after the procedure. Following that, these eggs that we've collected will be inseminated with the sperm. So we take a semen sample on the day of the egg collection, and following the insemination of the eggs become embryos, fertilize and become embryos. And then these embryos then develop in the lab for a few days. And then the final stage is to replace the embryos back in the uterus. However, this fourth stage, if you're doing genetic testing, is delayed until we test the embryos and we're able to know which embryo that we're going to be used. So this is just the difference between IVF for genetic testing and any IVF that is done for, let's say, fertility issue. Now, there's two ways of doing the insemination of the eggs. One of them is the standard IVF. And the standard IVF is normally done if there's no issues with the sperm. So if the sperm sample is normal, then we do just the standard. And it's basically what we do is that we put as you can see here, these little wells, you can see them all. We put each egg in one of these wells and add a number of sperm to these eggs, allow them to fertilize overnight in an incubator. Next day they fertilize, they become embryo. So there's very little intervention there except just creating the environment for the eggs to fertilize. The image on your right-hand side of the screen, that shows you this big sort of brown circle. This is the egg, actually. Looks a little bit like a planet there, and you can see there is these kind of hairy tentacles that is coming out of it. These are the sperm, and that shows you the discrepancy in the size between an egg and a sperm. There's a huge discrepancy in size. Egg is the biggest cell in the body, so it's not, and sperm is one of the smallest probably. So if there is any issue with the sperms itself, then we do another technique we call ICSI or ICSI, or intracytoplasmic sperm injection. And this is if you are worried that the sperm is not able to fertilize the egg on its own. Now we inject the sperm inside the egg. You can see here, this is just a video there of this process. This is a needle. This needle is about 1/20th of a hair, a human hair size, so it's very, very fine. That's all is very magnified under the microscope. You would see that there's a sperm inside at the end of that needle, and that sperm now, very tiny, like a little dot, will be injected right now into the egg, and then the needle is being withdrawn after that from the egg. And a few hours later, once you do that, then we expect the egg to fertilize, and then the embryo start to develop. Now, once the egg fertilized, then it goes through a stage of development, about 5 to 6 days of development in the lab. So you can see here on the first image, this is when the egg starts as one cell, and then this one cell divide into two, and each of the two divide into two, and so on. You can see the second image. It's about maybe 6 cells. That's around day 3 of the development of the embryo. And then the next image to it, the cells still continue to increase, but they are very compact, and it's harder to count them. You see, it's much harder to count the third image compared to the second image. And then finally, the egg goes to the final stage, it's around day 5 or day 6, which we call the blastocyst stage. And that's a very important stage because this is where the biopsy of the embryo is done. So you can see maybe the 1, 2, 3, 4, 5. So the image at the bottom before the last, you could see there on this side. This is actually the embryo, becomes the baby. Okay, and what's around it is the shell, which will become the placenta and the membrane. And we take the biopsy. We don't take it from the embryo itself, but we take it from the shell because they're the same origin, gives it the same information, but we don't have to biopsy the embryo directly. It's safer, and we get the same information. The last image over here is actually the embryo start to hatch, or like an egg that hatches, comes out of its shell, ready to implant. And that's what happened in nature, really, before it implants. Now, we now use a time-lapse incubators or time-lapse technology, which means that we don't have to take the embryos out of the incubators anymore. We're able to get a lot of information about the embryos through the time-lapse technology without having to, which have been very beneficial, really, for embryo development. You can see here, This is the stages that we just explained through the time-lapse incubation. So we start with one cell, and you would see that cell now will start to divide into two. And then again, all these development happen very quickly. An embryo start as one cell, by 5 days is 150 cells. So it's a phenomenal rate of development. So that's here when it started to, the cells harder now to see, to count the cell. That's around day 4 of the embryo's development. And then you will see now the next, I think, part. Yeah, that's the blastocyst stage where the biopsy is done. And then here the embryo is trying to hatch, see breaking through the top part of the shell to try and come out of the shell. Okay. The same pattern what happened in nature, even in a natural pregnancy, but we can see it under the microscope. Now, the final stage of, once the embryos reach that final stage of the development, this is the stage that we do the biopsy of the embryo. And the biopsy itself, this is another video that's just going to explain how the biopsy is done. It takes about 2 weeks, a small sample that is taken from the outer shell of the embryo, put in a little test tube, and then sent to the genetic lab. Now, the genetic lab has been ready with the test that is going to be used, and it takes about 2 weeks for the results to come back. Once the results come back, we are able to meet with the patient or the couple, discuss how many normal embryos. And that's an important step, really, because one of the aims of genetic testing is not only to have a baby, but sometimes a family as well. And if there's any surplus embryos that can be used, what we do is that these embryos are cryopreserved or stored so that they are be able to use in another year, 2, 3, 4, 5. Embryos can be stored as long as you want them to be. And that's important because normally the chances of achieving a pregnancy becomes lower with age. Age is a very important factor to it. And doing genetic testing and selection is always better to be done when the reserve is good, when the chances of success is good. But if you have embryos that are frozen, it means that even if you are in late 30s or early 40s, women's age is not the issue, it's their egg age really is the issue. So the chances is not different if they have an embryo that has been frozen. I'm just going to just show you, just out of interest, this is a video of the embryo. And by the way, embryo at this stage, when we take the biopsy, is about a very fine grain of salt. Okay, so it's hardly you can see that embryo. And so this process really, I mean, the embryologists very, very highly skilled that do this. So they take a few cells, as you can see here, try to just a negative pressure to take a few cells with a very thin glass pipette, and about maybe in the region of about 5 cells of the surface of the embryo are enough for diagnosis. So, and then once they have the right amount, and the right amount, it's neither too much or too little. It's a very delicate process actually. And then you can see here, over here, this one, they determined that, oops, sorry, excuse me. They use a laser sort of beam to cut this part of the cells. So I said it's a very highly skilled process. Once they take this sample, then this sample is going to be placed in test tube and then sent to the genetic lab. So obviously this is a quite, it takes longer than that. It's maybe quite slightly accelerated process. And you would see here at the end, just the sample that have been produced. Now, just the last thing, do I still have a little bit of time? Yeah, perfect. Perfect. Yeah, so one of the, that's the sample here that was taken. That would have probably about maybe in the region of 5 cells, which is okay for diagnosis. Actually, it's not only the genetic side of thing that is checked in these samples, but also we check for any underlying chromosomal abnormality. Because embryos, chromosomal abnormalities are quite common in embryos because this is how eggs age. So by being able to test the embryo as well for chromosomal abnormality, then the chances of success, only chromosomally normal embryo can result into a healthy baby. So it improved the chance of success, but also reduced risk of miscarriage and risk of congenital abnormality, like Down syndrome and Edwards syndrome and so on. Embryos that are tested can be frozen. No, we say in general, anywhere we see maybe women or couple are using their embryos between 5 to 10 years, which is probably the reproductive age, depending how early they start this process. But embryos can be stored indefinitely, really, and age is not a major factor. This is just an image. This is the team of the Beacon Care Fertility. Sharon, this is the lab where they do most of the genetic testing. And thank you very much for inviting me. Really, it's an honor.
I want to knock you out. Thank you so much, Dr. Omar. And I have to apologize that you had to keep going back and forth. The pointer worked for the projector, but not the TV. So, yeah, I think that was a fantastic presentation. And unfortunately, Dr. Omar has to fly back to his busy clinic, so he can't stay for the Q&A, but I believe we can email you any questions. Yeah, so that's fantastic. I don't know if we have any time left before coffee break. We have 5 minutes if anybody wanted to get a question in. Would that be okay? Yeah, I see hands up already. I know we've got the roaming mics. I'll just grab my apologies, we're wired for sound here. Don't trip. I'll grab the mic.
Oh, yeah, perfect. Yeah.
Hi, just two quick questions. Does Beacon Care, does it do egg freezing?
Egg free, yeah.
So you can do that and then come back
Yeah,
10 years later
and it is an option again if especially for single women, the option of freezing eggs is an option. We just would ask as well to go to the same steps of genetic counseling and so on, but definitely if especially for young women, single women, they can freeze their eggs rather than creating embryos. However, if you have a partner, freezing embryos is always a better option because we know much more about embryos than eggs. I mean, we don't know the quality of the eggs until the eggs are used. Okay, now we rely maybe on age of the egg and so on, and that's a good predictor. But in general, embryos freeze much better than eggs. They survive the thaw much better than eggs. Embryos survive the very robust structure. So 98, 99% of the embryos that you freeze will survive that process. Eggs now, survival is much better because techniques have improved. We expect maybe 80, 85% of the eggs to survive, but there's much more information that you get from an embryo than you get from an egg. But definitely it is an option if women are single, they don't have a partner, they can always freeze their eggs rather than embryos, especially if they're thinking of delaying their fertility for a while, yes.
And I suppose for, say, young women who are BRCA, kind of positive, would you be kind of suggesting or advising that they perhaps consider something like kind of egg freezing in their early 20s?
Yeah.
I appreciate you say embryos are, better to work on.
Yeah.
But that, maybe the upside of the younger eggs is worthwhile considering.
Oh, absolutely. And to be honest with you, it's always when there's any genetic condition that can have an impact, might be on fertility in general, the major advice, and we see a lot of gynecologists are doing that already. They're referring maybe young women that they see that they feel that they are at risk, not necessarily only from genetic condition, but any condition that can affect fertility or might have a long-term effect on fertility, they refer them for egg freeze. It's a very good option. And by the way, as well, now we are introduced in the last year using the AI technology, which help us to predict a little bit more about the quality of the eggs, which we didn't have in the past. So things are better than what they used maybe 3 or 4 years ago regarding to egg freeze.
Thank you.
No worries.
That's another hand up.
Same question.
Thank you so
Oh,
much.
sorry, it's so much.
Here.
Yeah. We have not as many, but we did have treatment for male partners that had issue with that had been diagnosed with BRCA, okay, because of the risk as well. So that can be done. Now, regarding to the sperm, they don't necessarily need to freeze sperm because you see, sperms are slightly different than eggs. So sperm are not born, eggs are born with women, so they're the same age. So, and you don't produce any more eggs after birth. So the number will reduce, but also the quality will reduce. But with sperm, it's slightly different. Sperms are produced periodically. The oldest sperm that a man has is about 74 days. If it's not used, it's replaced by another sperm. So if there is an issue, though, with the quality of the sperm, obviously we say that they can freeze a sperm in advance. But yes, you could do genetic testing if the male partner is a BRCA gene carrier. You could still do the same process that we do with genetic testing and so on. Okay. Thank you. Thanks very much. Thank you. Thanks.
Excellent. I think the videos were great, weren't they? Yeah. Yeah. So thank you so much, Dr. Omar. Thank you to all our morning speakers. To Michael and Trina. And now it's time for coffee. So are people cold? Yeah. Hi, everyone. We're going to resume. So you can bring the coffees back to the tables. I want to shorten your presentation, get everybody. I need a bell. That's what I need. Give us the flasher. Everybody's attention. Can we get you all back? Don't know how to turn it off. Thanks, Jane. Okay, so we're going to get started. So I'm going to get everybody, if you don't mind, we'll get a bit of P&Q back in the room. I hope you all enjoyed your coffee. So we're on to our next wonderful speaker. I hope you can hear me. I'm number 7 of 9, so I tend to be quite loud. So anyway, our next wonderful speaker is Dr. Samantha Cushen. Pronounce your name correctly. Samantha is a Kuru registered dietitian with a PhD from University College Cork and a full-time lecturer in dietetics at UCC. She is committed to improving cancer outcomes through her research on nutrition and body composition. Samantha is particularly dedicated to improving quality of life for female cancer survivors and is currently leading on an innovative project to create the first ever Irish nutrition guide tailored specifically for female cancer survivors dealing with treatment-induced menopause. Samantha also has a copy of her book here today, so I'm sure she's going to talk to you. So I'm going to hand you over to Samantha now.
Okay. So good afternoon. Is it afternoon yet? It's probably still morning. Good morning, everyone. I'm delighted to be here, and thanks to the Mary Keating Foundation for inviting me to speak. I'm going to be taking you through a whistle-stop tour on nutrition for surgical menopause. This is a professional interest of mine, but also a personal interest. In 2022, I went through my own risk-reducing surgery. So I have lived, breathed, eaten every bit of advice that I'm going to present to you today. The other element of this presentation is to present to you specific nutrition advice for women with BRCA. I think when you go to see nutrition talks for cancer, for example, a lot of the time the advice is very general. This is tailored to women with BRCA. The research I'm going to present to you has been done in women with BRCA. And that's what I think is quite novel and unique, because the research is quite new and it's only been evolving within the BRCA sphere for the last couple of years. So what I'd love for you to get from today's presentation is to understand what the unique nutritional needs are of someone with BRCA. And I'm going to take you through a journey of why we need to focus on nutrition for the different stages of your journey with BRCA. To be able to identify key nutrients and foods, dietary patterns that can support not only your menopausal symptoms in the short term, but protect your health for the long term. And that's what my main role is with women. It's not just about now and the short term of goals. It's about protecting and investing in your health for long term, for the next 20, 30 years. And then ultimately, I would love for you to leave today a bit more empowered in that you're not being told to go on a diet. You're not being told to restrict foods, to stop eating certain things. You're going to come away from today going, oh my God, she told me to eat more, eat more, eat more. So it's to give yourself more personalized advice, information you can take home to your families, to your partners, that you're not going to be on a special diet, that we can all eat the same way. And it's all evidence-based. And I think that's what's key, that there's research backing up everything that I'm going to speak about today. So when we think about nutritional considerations for BRCA, there's actually lots of different considerations. I'm only focusing on one today, which is menopause. If you are going down the surgical route and you're going down for a risk-reducing surgery to have your ovaries, your fallopian tubes, maybe your uterus removed, we actually have to be thinking about nutrition then, before you ever go for surgery, to build yourself up for surgery. What I'd be focusing on in that stage would be protein. Why? Because in the post-surgery phase, wound healing is really, really important. If you go for a bilateral double mastectomy, you will have drains. You may be losing serous fluid and you might be losing some protein in those drains, for example. You'll need protein for wound healing, for muscle synthesis. In the first 2 weeks after your surgery, whether that be mastectomy or oophorectomy, you need to focus on wound healing. You need to focus on just eating to get yourself out of the bed. From the research we've done in UCC, we know that for every day you stay in bed, in a hospital bed, you're losing muscle mass. Muscle mass is linked to your outcomes. It's linked to your quality of life. It's linked to cancer treatment. But from a surgery point of view, the more muscle you have before you go in for your surgery, the better your outcome. You'll be more likely to get out of bed afterwards, to do your physiotherapy, and to get home. That's what's key. What we're going to focus on in a few more slides is the menopausal aspect. What I would have loved to know before I went in for my surgery is, do I need supplements? What supplements do I need? How much do I need of the supplements? None of this information was available to me. What food should I be eating? Am I going to have really, really bad menopausal symptoms? Are they going to come straight away? For how long? Are they ever going to leave? Am I going to gain weight the minute I wake up from my surgery? Am I going to gain weight? How much weight? Can I lose weight? And then for women who get a cancer diagnosis, their nutritional needs are different, depending on the cancer they have, the treatment they get, the side effects from the treatment that they get. So the nutritional information and nutritional advice for someone with a cancer diagnosis will be more tailored to those individuals. And then at the heart of everything we have is cancer prevention. We go for risk-reducing surgery to prevent cancer. So at the back of everything we do, the nutrition advice should also be tailored for cancer prevention. And here's the good news. Everything that I talk about today in relation to menopause, the dietary advice, it's all linked to cancer prevention as well. So we're going to focus here on menopause. So risk-reducing surgery satellites a woman with BRCA into surgical menopause. It's fast, furious, intense, and it is very, very scary in some ways for some women. From a nutritional point of view, we do know from the research that surgical menopause does lead to it can lead to higher rates of osteoporosis. So our bone density is lower. There is some research to suggest that going through an oophorectomy links to higher rates of dementia. Now, again, the research behind the dementia link, it's not as clear-cut and it's not as strong as the link for bone density, for example, but I'm still going to talk about it in relation to the dietary advice we talk about today. And then there is a lot of research to support the fact that going through an oophorectomy will increase your risk of heart disease. So I'm not presenting this information to scaremonger. I want you to use this to empower your dietary decisions. Take the focus off weight and focus on bones. Take the focus off weight and focus on your heart. If we focus on protecting our bones and protecting our heart, the dietary advice that I'm going to show you for doing this is going to have a lovely beneficial effect on your weight anyway, but it changes your mindset around food. And that's what I love to try and do with women. Try and focus on enjoying food, quality of life. Going through a big surgery like oophorectomy, hysterectomy, or a salpingo oophorectomy, you're going through so much. And in the back of your mind, you're also thinking about trying to prevent cancer. Don't let weight be at the forefront of your mind. Don't let weight overcome your quality of life and living for the next 20, 30, 40 years, having a good life and enjoying your food. I'm telling you, if you focus on your bones and your heart, that's the best thing you could do for yourself. And it's the best thing you could even do from a family point of view as well, because the dietary advice will not only benefit you, it's going to benefit everyone else in the household as well. So with risk-reducing surgery, body composition does change. Now, this happens anyway with a natural menopause. It just happens a bit more extreme. I'm going to show you in a few more slides with oophorectomy and with the surgical menopause. So what happens is we tend to gain weight, adipose tissue around the midsection. Our hip and our waist start to get wider. And this is a combination of effects. There's no one single reason why this happens. We also, at this stage in our life, usually around from the age of 40 onwards, we start to lose muscle mass, and that's a natural consequence of aging. But that, coupled with losing our hormones, losing estrogen as a result of the surgery, it just accelerates that fat accumulation on the body, unfortunately. Our gut microbiome, I'm going to talk about as well, because there's a lot of research going on in that the women who are going through a surgical menopause, their gut has changed. The gut microbiota, the bacteria in your gut changes. What that does, we have what we call a gut-brain axis. Your gut is connected to your brain. It's a two-way signaling system. You need good, healthy bacteria in your gut to have a good, healthy brain, in real simple terms. So where the research is evolving here is looking at the links between our gut health and brain fog, fatigue, sleep disturbances. That's why they're all interlinked. And then, yes, during menopause, our metabolism changes slightly. It doesn't change that dramatic that you might see over social media. It's actually only a very slight change in the way we metabolize carbohydrates and fat. The majority of the links to metabolism are actually linked to muscle mass. So I'm going to focus a lot as well in this presentation on protecting muscle mass. The more muscle you have, the more calories you burn at rest. So even when you're sitting here listening to me, the more muscle mass you have on your body, the more calories you're burning. So that's why metabolism is linked with muscle mass, and being physically active is really important to help maintain muscle mass. And then during our surgical menopause, lifestyle patterns completely change. There's lots of evidence to suggest that women who go through a surgical menopause have decreased levels of physical activity. The knock-on effect, decreased activity, decreased muscle mass, poor bone density. The symptoms come in here, menopausal symptoms, of which you know there's at least 40, there's new symptoms every day adding to the list of menopausal symptoms. They impact on your lifestyle. If you're not sleeping well, you're not going to be able to get up the next morning to go and exercise. And you'll be fatigued, you'll be exhausted. So what do? You start picking really high calorific snacks. You go for the options that aren't, I suppose, the healthiest options. And that's all been researched as well. So if you're ever looking for a researcher who specializes in menopause after cancer or surgical menopause, Martha Hickey is a really good person to Google. Martha Hickey is a professor in Australia, and she does a lot of research in this area. And I'll be presenting a lot of studies that she's been involved in. This is one study just to show the difference in body composition between women who go through a surgical menopause versus women who go through a natural menopause. So what they did is they got a group of women and they split them into two. They had the women who went through a surgical menopause, and they had 99 women as a comparable group. These women retained their ovaries. They went through a natural menopause. They tracked and followed these women for 2 years. What they found at the end is that both groups did gain weight. So around 50% of women will gain weight during a natural menopause. However, when they compared the surgical group to the natural group, the women in the surgical group, so it's RRSO here for short, they gained nearly 3 kilos of weight in 2 years after their surgery. Compare this to the natural group. The group that went through a natural menopause, they gained weight, but a lot less, significantly a lot less weight. And neither groups of women did anything different. They didn't eat differently, they weren't different ages. It was just that the surgical group gained more weight. And here is the most important thing to take away from this slide, is that the women in the surgical group gained more visceral fat. What that means to you. Visceral fat is the fat that's inside lining your organs. It's metabolically active. It's not a good fat to gain. Subcutaneous fat is the fat that's just underneath the skin. You gain that around your hips, your buttocks. That's safe fat to gain. You can lose that quite easily. Visceral fat is a fat that actually releases inflammatory hormones in the body. Visceral fat is the fat that's linked to cancer. So that is why women who go through a surgical menopause, straight away, we need to be thinking about body composition. What can get rid of visceral fat? Physical activity. Even if your weight on the scales doesn't change, and you stay at 80 kilos, if you're physically active, we've been able to show, and I can show countless studies, you can decrease down that visceral fat, even if your weight it doesn't change on the scales. So that's why being physically active, no matter what weight, what size, is going to benefit you. So, what to eat? What's the best thing to eat? What's the best foods to eat for going through menopause, but also for cancer? What we need to think about is your health, number one. So the dietary advice needs to impact on your health. So I want to be thinking about your bones, your brain, and your heart. That's what I want to give you information for. And I also want to give you dietary advice that's going to help with hot flushes, sleep, night sweats, brain fog. There's no secret here. It's Mediterranean-style dietary pattern. I probably could have just said that at the start and then stopped talking. That would have been easier. But then you wouldn't have listened this far. So I have you where I want you. Mediterranean-style dietary pattern. If you're sitting there going, oh my God, I know this. Why is she saying this again? Well, brilliant. Then my job is done. Here's the thing. We don't follow this. Mediterranean dietary style pattern would advise that we eat at least 30 grams of fiber per day. In Ireland, we eat 17 grams of fiber per day as adults. So we don't eat this way. We all know about it, but we don't eat this way. Mediterranean-style dietary pattern advocates for having around 4 tablespoons of olive oil per day for benefits. It's around 3 servings of nuts per week, 3 servings of seeds per week. It's having at least a minimum of 3 pieces of fruit per day and at least a minimum of 2 vegetables per day. Now, if you listen to that, does that not just sound like healthy eating dietary advice? Because it is, but we don't follow that advice. All the research I'm going to show you in the next few slides, they use this information, these quantities, to show beneficial effects. So every time you see on the next few slides, Mediterranean-style diet, this is what they're talking about. This is what they used in the studies. They put the women on 4 tablespoons of olive oil per day. They got them to eat at least 3 pieces of fruit per day, at least 2 vegetables per day. And I am going to just say one thing, because you're going to be pinpointing this and asking me about this later. Yes, in a Mediterranean-style diet, red wine is included. Okay. However, we're talking about cancer here. In the studies I'm going to show you, they did not, unfortunately, include red wine in the diets. Okay. So I'll leave that up to you at your own discretion. But from a research and public health point of view, I'm not going to be telling you to go out and have red wine or I will get fired. Okay. So even though it says Mediterranean-style diet, it's not a diet. These are guiding principles. Yes, you'll have the most beneficial effects if you eat these quantities here on this slide. But if you even change one thing, if you increase in just 1 more piece of fruit per day, you're having a benefit. And the studies have shown that. So these are guiding principles. What I like about them as well is this, to me, is normal food that everyone in my house can eat. It's not just I have to go and eat these foods. This is the way we should all ideally be eating. So I'm going to try and sell to you that The Mediterranean diet will help with your hot flushes, mood, sleep. It will not eradicate symptoms. No pill, no magic herbal supplement or menopause supplement will do that. No food will do that, but they will help decrease the intensity and frequency, but they won't eradicate them. But here's the main thing. The Mediterranean style dietary pattern, it's the foundation for which everything else is built on. So I'm going to show you that this can be linked to cancer risk reduction. And I think that's what's key for everyone in the room as well. It will then also protect your bones, your heart, and your brain. And it's all focused on gaining health gains. It's not about weight loss. It's not about cutting out foods. It's actually about adding in more. Okay, we're going to fly through this. So there's a few research teams around the world who are now looking at BRCA and nutrition. This group from Italy, they wanted to see what are the main characteristics within women who have BRCA that lead to cancer. That's what I want to know. Like, what sort of body composition, lifestyle factors are linked with higher rates of cancer incidence in women with BRCA? So what they found here with these women, it was over 500 women. They were around 46 years of age. Women who had higher fat mass, and it was in particular visceral fat, was linked to higher rates of cancer with BRCA. Women who had 4 or 5 of these metabolic risk factors, okay, and I'm going to highlight these on the next few pages. But if they had insulin resistance or higher rates of, see this little hormone here, IGF-1, that stands for insulin-like growth factor. You don't need to know much about it, but it's a hormone that's been linked to cancer incidence. That is higher in women who have higher visceral fat. That is linked to cancer incidence. So they're able to profile these women. So they profiled them, and then they said, right, let's now take those women who have the higher rates of cancer incidence and give them food to try and counteract those metabolic effects. Can it be done? Will any improvement happen? And yes, they had 400 women. They split them into 2 groups, and they gave one group Mediterranean-style dietary advice. They did nothing with the other group. They told them to go off, eat normally, whatever way you eat. The women who were given the Mediterranean dietary advice, in 6 months, and in research terms, 6 months is very short, so that's really good. For you, it's probably like, oh my God, it's so long. This is no quick fix, but in 6 months, they saw an improvement in that hormone I'm talking about, insulin-like growth factor. That's amazing that they saw that. And this was just by Mediterranean dietary pattern. There was no other advice. They lost more weight. It wasn't even one of the intentions of the study, but they actually lost weight eating this way. They had greater reductions in their waist and their hip size. The knock-on effect for that is they're protecting their heart. The minute your waist and your hip size goes down, your heart risk, your cardiovascular disease risk goes down. The diet was also associated with lower cholesterol. Again, this is helpful for heart disease. So they were able to show Mediterranean diet helps with the metabolic effects of BRCA. Again, similar story here. I just wanted to re-emphasize and try and show you again in another study, 200 women here who had BRCA mutations. They gave them dietary advice based on Mediterranean-style principles. And again, in 6 months, the women saw a decrease in their weight, hip size, and that hormone I'm talking about, IGF-1. Now, what was key here is that they saw more improvements the more plants the women ate. I'm not advocating for vegetarian, vegan diets. You don't need to follow vegetarian or vegan. Still have red meat if you do eat red meat and chicken and fish. Just include more plants into what you're eating. So the way I would advise that is if you have spaghetti bolognese, add in extra pulses into your spaghetti bolognese. You don't have to cut the meat out at all. Just fill up on more pulses. You will have beneficial effects. How long will it take to see the changes in your metabolism, your metabolic profile? 6 months. It's a lifestyle change. This is not a diet. This isn't a quick fix. This is something you're doing to invest for your health. Now, when it comes to symptoms of menopause, the studies have not been done in BRCA women. The results from the large studies looking at Mediterranean-style diet decreasing menopausal symptoms have actually been done in healthy populations. However, what we can say in women who have gone through like natural menopause, not to say that we're not healthy, that's an awful term, in natural menopause, adhering to a Mediterranean-style diet can decrease hot flushes and night sweats by around 20%. It will take 6 to 12 months, though, for this to actually have an effect. So we can have an effect on menopausal symptoms, but it's not instantaneous, which is the main thing. And then again, there's been links with Mediterranean diet and developing, or the decreased risk of developing dementia. Now, I've spent far too long in the first half of the presentation that I'm going to fly through the rest. And please then use the question and answer time if you want to ask me more specific questions. I always focus on sleep as the major symptom to try and get under control if this is your major symptom, because sleep is linked to your physical activity, to your eating habits, to your body composition. Women with BRCA who have poor sleep quality, they actually have lower rates of physical activity. It's a kind of cause and effect. You sleep bad, you won't exercise. So sleep quality, prioritize. And I can say that lovely, and I'm just saying that, but I know how hard this is, especially if you've got young kids and especially if you're working full time. Sleep is horrendous during a surgical menopause. So from a dietary point of view, what can you do? There's lovely guidelines out there to talk to your GP around pharmacological and medications for helping with sleep. Caffeine reduction, alcohol reduction can help with better sleep quality. 2 kiwis, 1 hour before bed. Have you ever heard this? There's actually research behind 2 kiwis 1 hour before bed can increase your sleep quality in 4 weeks by 14%. It can decrease down the rate, you know how long it takes you to fall asleep? It can decrease down that length of time for falling asleep by 35%. 2 kiwis, 1 hour before bed. There are no side effects from having 2 kiwis 1 hour before bed. Perfectly safe, full of fiber, full of vitamin C. If anything, if it doesn't improve your sleep, at least you're getting an extra portion of fruit per day. But it can help with some women. Magnesium, 300 milligrams, magnesium glycinate specifically, 300 milligrams. Some women find that effective. I'm not saying that it is effective. It will help with bones as well. There's no major contraindications for taking magnesium. Now, I am definitely up to time, so I'm going to just signpost you here. All the fancy fad diets that you see advertised on social media. This is one I took from last week, the 30-30-30 diet. 30 grams of protein each meal, 30 grams of fiber per day, 30 different plants per week. Guess what? It's Mediterranean style diet. They just put a label on it. They're selling a book. The Zoe Predict study in the UK, Tim Spector, you might have seen him on social media. He has his own lovely little gut health shop being sold now, Marks and Spencer's. Talks about 30 different plants per day. Guess what? Mediterranean style diet. I'm saving you money. Fruit and veg. And no one wants to say this, but it's more fruit, more veg. That's it. And what counts as a plant food? Dark chocolate counts as a plant food. So you can tell them, you're welcome. So you'll all have 30 different types of dark chocolate per week. Benefits of fiber. Helps your bowel, reduce inflammation. I am nearly finished, I promise. Lowers cholesterol. Loads and loads of research behind fiber. Guess where you get your fiber? Fruit and vegetables. I should actually sell fruit and vegetables, I think. But here's the good things for breast cancer. We all know about fiber. You've probably heard about fiber and the links to colon cancer. There's lots of research showing the benefits of fiber decreasing breast cancer risk. That's why I push fiber. I push fruit and veg for this reason. Every single extra gram of fiber you have per day will help with your breast cancer risk. No matter if you go home today and just have 1 extra apple per day, you're already helping yourself. Again, another lovely diet that's come out, the NEMI diet. This is a free dietary plan that's online. The only thing I will say in the way I support this, because Jens Walter is a professor in UCC, so I support other fellow researchers. But look at the plate. What's on the plate? It's all fruit and veg, because it feeds your good gut bacteria. And this is what it looks like in a day. It's all fruit, all veg, but there's also meat there. It's very colorful, very plant focused. And that's the premise behind Mediterranean style diet. So what did I do? I decided to go and create my own. And this is free, by the way. So this book, it's endorsed and published by the Irish Cancer Society. It's a resource for women who've gone through menopause as a result of cancer. You do not need to have gone through cancer to follow the dietary advice in here, because guess what? It's all Mediterranean style diet. I didn't make it up. I basically took Mediterranean style dietary information. But we did create a menopause plate because we were dealing with women in a big clinical study down in Cork who'd gone through surgical menopause, and they'd gone through cancer, but they didn't know where to get evidence-based dietary advice. There's a whole chapter in here about supplements because I haven't even got into supplements with you today. This is free. It's being released at the end of this month. There'll be a PDF of it online on the Irish Cancer Society, and just keep an eye out on Mary Keating Foundation social media. I'll make sure it's kind of signposted everywhere. But this is what the book looks like, and there's lots of recipes at the back of the book. The first half of the book is all information related to symptoms, nutrition and symptoms. It's for women who choose not to take HRT or who can't take HRT. What else can you do? It's all in here. So this is what we have in the book. It's an Irish equivalent of a Mediterranean diet, because this to me is like a typical kind of Irish style diet. This contains 30 grams of fiber. Having your porridge, and I'm 4 minutes over, I really apologize. Porridge, sandwich, yogurt, berries, meat and 2 veg, boom, you've got your 30 grams of fiber. So it's a lot easier than you think. It's just adding in more fruit, more veg. I also focus in the book around the microbiome and feeding the gut. And again, it's just fruit and veg, fiber to help. So instead of going for that supplement straight away, think about your magic menopause plate that will help with your body composition, your bones, your brain, your heart health, and then the knock-on effect for your symptom control as well. In the book, we link all of the foods in all of the recipes to all of your symptoms. So we try to show you where the benefits lie in eating a salmon and rice dish or eggs on toast. I'll pull out that in eggs, there's a lovely nutrient called choline. Choline is really good for brain fog. So just information like that for women. This is my final, I promise. If you have questions around supplements, About Herbs by the Memorial Sloan Kettering, they have a really good webpage, but they also have an app that you can download. If you want to Google and research, they'll give you evidence-based information on supplements if you are looking at supplements. And I'm happy to answer any questions on supplements, but I've already talked to Bernie. I think we need a separate session on supplements. Today, I wanted to signpost you to the information around menopause Mediterranean diet. Get the foundations, and we can add in all the extra, I call the sprinkles on top, are the likes of supplements and all the other added extras. Get the foundations right, and everything else will follow. This is another lovely free resource, Truth About Cancer, from my colleague, Professor Aoife Ryan in UCC. Brilliant resource. Breakthrough Cancer Research is where you'll find this. You can order it for free. It's a lovely booklet. It goes through like the sugar feed cancer, dairy feeding cancer, everything like that. And my takeaway message is just eat more fruit and veg, really. I could have said that maybe at the very beginning, saved you 31 minutes. I'm really sorry, really sorry. So thank you so much for your time. Thank you. Sorry.
That was brilliant. Thank you so much, Samantha. It's kiwis and coffee next year, not scones and coffee. So thank you so much. That was excellent. So save your questions. Because after our next wonderful speaker, we will have a Q&A time. So we're just going to switch over here. Before I bring on Mr. Jamie Martin-Smith, I'm going to have to read all of this. I think it's fantastic. Jamie, will you introduce yourself then? So Jamie Martin-Smith is a consultant in plastic surgery in Beaumont Hospital, Connolly Hospital, Blanchardstown, Bon Secours Hospital, Dublin, and the Mater Private Hospital. I think Jamie is going to do himself justice here in talking primarily about what he does, the great work he does. But I think one big line that stands out for me is that Jamie performs at least 50% of all DIEP breast reconstruction in Ireland in 2024. So is that right, Jamie?
Between Beaumont, so no, I have colleagues as well. Between
Oh.
Beaumont and the Mater Private, we do
Yeah.
half of all the DIEPs in the country.
Half of all the DIEP. So I think, Jamie, I can't read all of this because I'll take up a half an hour.
I didn't know that. I thought it was going on a website.
No, it's going on here. Everybody keep reading there while I switch over. Do you want to switch? Yep, or you're on here, whichever is easier. Okay, well, I take this out of the way then. Let me just see.
That's good.
Yep, up here as well.
I'm the only speaker who didn't actually transfer slides.
Oh, we'll say nothing to you. I'll give out to you after.
Yeah.
Do I need to switch that one as well?
Just leave it.
Leave it there and you can just sit and will you be able to?
Yeah, fine.
Okay. You know what he's doing. Oh, you're there, you go. You practice this. Right.
So, okay.
Sorry, I didn't give Jamie justice in his introduction there, but I think you'll see from the presentation Here, I think it's coming on now. There we go. Yeah.
Thank you for the forms. Is working. Everyone can hear me? I guess it's like a massive topic to talk about reconstruction because there's so many, nuances and options, and it's like a decision that you have to make as well. So I guess I just try and do a whistle stop tour. Definitely can run slightly over. Apologies, and I'll just do my best and then try and answer some questions at the end. That's not great. Yeah. So just ideally no photos. I mean, there's pictures and things on this. So if you think about cancer reconstruction in what we normally do in hospitals, plastic surgery is reconstruction. So normally there's a hole in someone's leg and the primary objective is, can we close the hole? And once we close it, can we restore the function? And once we restore the function, can we get back cosmesis? And, in a leg or for other cancer reconstructions on the torso and body and stuff like this, the cosmesis one is way down the list because fixing the problem is fixing the first two. But in a mastectomy, your treatment of your illness or your genetic risk is just a mastectomy. And so by taking away all the tissue, you've done that. And so all we get to do in the reconstruction, it's purely going back to maintaining and restoring cosmesis. And therefore, you could argue it's not that important, but obviously, as probably being discussed, it's incredibly important in terms of your recovery and psychological welfare and healthy and well-being afterwards. So we don't really look at closing the defect. It's super safe, as in large cohorts. When you look at it, there's a big study that most of us quote from 6 years ago, 2,500 patients in the UK, and all types of reconstruction, no reconstruction, implant reconstruction, own tissue reconstruction. And they looked at all the outcomes. And they basically said that while complications are common, it didn't really change the end result in terms of extending your time to treatment. While that's not that important for BRCA, because hopefully you don't have any adjuvant treatments, it gives people the security of knowing that most breast cancers can have a reconstruction. Why this is important, we're picking up more and more breast cancers early, we're picking up more in situ disease, so there's more and more women that are affected by this, and more women are being cured really quickly and really early, and therefore more and more women lead a perfectly normal life, and therefore reconstruction, good longevity, good aesthetic outcome, good everything is just so much more important. Historically, it might have been that, a reconstruction was in a bad diagnosis and things like this, and there'd be other factors. But now so often women are just being diagnosed, treated, and they disappear back to normal everyday life. And so we have to look at what the gold standard is. If you look at the term gold standard, it's like in medicine, you come in, you say, here's your options, but the gold standard is this. Sure, everyone's just going to go, well, I'll have the gold standard, please. I mean, so it doesn't really translate to breast reconstruction because breast reconstruction is all about what you want. Okay, so gold standard is when there's like a medical thing that you have to do and that's the best for it. And there isn't a gold standard of breast reconstruction because it's not to do with that. Everyone's different. So everyone comes into me with a different idea of what they want. Some people come in super well read, so they know exactly what they want. Some people come in saying, my friend did this and it went terrible, I don't want that. Or my friend did this and it went really well and I just think I want that. Or I have no idea, I've never considered this. A lot of people come in and the first thing they say is, I just want something really simple. I have a busy job, I have 3 kids, I'm running my own business and things. They just want something really simple. And so it's important then, I have to almost knock them back a little bit and say, well, then you do realize your option here is a simple mastectomy. You don't do anything else. You just have a mastectomy. That is the simplest. So if you're looking to get out the door quick with no risk and not taking on any complication possibilities, you go for simple mastectomy. But of course, nobody really wants that, especially in the BRCA cohort, because it's totally reasonable to want to come out looking the same way that you went in. And so therefore, we escalate up the ladder in terms of talking about implants and own tissue and stuff. And there you've got to try and decide what are you willing to take on in order to get your outcome. So it's patient controlled. Immediate versus delayed is somewhat patient controlled. Certainly in the BRCA cohort, it's very much patient controlled because you can just say what you want. In a cancer situation, it's almost dictated by your breast cancer surgeon and whether they think it's safe or not. But most people are super safe to have a reconstruction. It depends on whether it's the right idea to do it. So if you need a lot of chemotherapy or radiotherapy, you question, should you put your body through a reconstruction? And so you're guided a little bit at the time. But in an immediate reconstruction, you get to keep all your skin. And in the delayed reconstruction, you take away the skin. Because if you take the breast away and leave the skin, it'll just fill with fluid and cause problems. So you take away the skin. And so therefore, for the reconstruction, you need different components. The breast is super simple. It's just breast tissue under skin on top of muscle. And there's basically 3 types of mastectomy. And this is kind of a key thing that nobody really labors on. So I'm just going to talk about it and hopefully my little thing comes up here. So the dotted lines are your mastectomy surgeon's cut. And so if you're doing a simple mastectomy, you're going to leave an undetermined or a length of upper breast skin. You're going to cut everything out below, and then the upper breast skin, this is a bad diagram, is going to then reach down to stitch the bottom, so there's no extra skin. If you're doing a nipple sacrificing, and you can see the way the breast protrudes to the nipple, so the nipple sacrifice is most common. If you're doing nipple sacrificing, you keep all the skin, but you take away the nipple, and so the breast surgeon has to tunnel in here. And that red line, that's like this mythical line that a breast surgeon has to figure out how thick do they make those skin flaps and how much tissue do they leave behind. And so, you know, for a risk-reducing mastectomy, it's risk-reducing, not risk-eliminating. It's because some cells have to get left behind the other side of this red line. But if a breast surgeon leaves, you know, a centimeter there, you're going to have a super reconstruction. That's going to hide everything. You're going to have a full centimeter of tissue the whole way around. So you put anything in, it looks great. If your breast surgeon leaves, you know, 3 millimeters of skin only, it's going to show everything. But then someone who leaves a really thin mastectomy is going to get the lowest recurrence rates because they've left less breast cancer. Someone who leaves slightly thicker is going to get a higher recurrence. So there's a little discussion that to be had that never really gets had. I work with quite aggressive breast surgeons, so I usually have very thin skin flaps, which I'm okay with. But there's definitely a difference. And then a complete skin-sparing mastectomy is you go in through anywhere in the pocket, be that armpit, be that under the breast, be that through the nipple, and you try to keep everything. And that's great, but it keeps everything in position, so you don't get the chance to change your shape. So if your breast is, you know, hangs low and you don't like the shape and you want it lifted, you can't really lift the nipple at the same time as not taking away the nipple. It's kind of an impossibility. First question I ask is, what do you think of the other side? Do you like your other side? Do you like what you have? Is this what we're trying to make? Because if someone comes in with like a H cup, most women don't want that replaced. So we make what they want and we reduce to match. And very rarely you might augment the other side to match it. And then you just ask, you know, what do you want to put in there? Do you want to use your own tissue as an implant? In terms of skin, usually in immediate reconstruction, we don't need skin. Delayed, we've got to get skin for somewhere else, or we can make skin. Making skin is expansion, and that's a delayed reconstruction, which everyone will know about to some degree, but hopefully in the BRCA population, you're not having to think about it. If you put an implant in, it needs support. Own tissue will stick to you. So you put own tissue in and it eventually just becomes part of you. And so when it hangs and it stretches and things like that. But an implant will always need something to hold it and cradle it and support. And so we talk about support for an implant, otherwise you end up with the rock and the sock theory, which is never a good thing. And the rock and the sock is historically, they used to put implants just under the skin, and eventually it stretched so much that it looked terrible. And then they moved everything to under the muscle to try and protect the implant. But now we know that in front of the muscle is probably a better option for most women, but it involves a few more steps, which I'll mention later on. Implants are pretty safe now. It is silicone in your body, which some people have a fact, you know, not having that, and some people, I don't really care. I mean, loads of people put in silicone for augments and do very well and things like that. They're very good. You know, when you cut them, they don't spill out. You know, if you get a ruptured implant, it takes a long time for that silicone to become liquid and cause a problem. But yeah, if it ruptures, it causes a problem. And so that's one of the downsides of implants. Texturing is one of the methods that we used to use on implants to create an implant that was more stable and didn't move and, you know, less reaction to the body. But we found that texturing caused a little bit of interaction with the body, and then it led to this thing that's about 1 in 70,000 risk of a lymphoma. And so if you're telling someone they're going to reduce your breast cancer risk, but I'm putting an implant that might cause lymphoma, it's a really hard thing to sell. So, you know, when I say sell, I'm not selling. It's a really hard thing to get over in terms of discussion. So pretty much everyone goes to a smooth implant. And a smooth implant is a little bit more mobile, and it can't be shaped. So a smooth implant is going to turn inside you. And so if you've got a fullness down the bottom and narrowness up the top to create a breast shape, once it turns, it'll look silly. So a smooth implant has to be round. And the theory is, please, surely. The theory is that once you pick up a smooth implant and you turn it on its side, the gel kind of displaces to create an anatomical shape. I'm freezing now. Please help. No, there we go. Okay. Would love it to play. Anyway, so when you turn them on the side, they kind of look the same. So there's not a huge advantage to the textured implant, and therefore pretty much anyone you'll speak to will move towards a smooth, round implant as opposed to a textured, anatomical or breast-shaped implant. Structural support, we used to always put under muscle. So the latissimus dorsi muscle comes around, and that's your structural support, or you put it under the pectoral muscle and you expand, and that's your support. And we've very much moved away now to not stealing one of your major muscles. The LD, your pec, they're huge shoulder muscles. We don't use them as much anymore. Still definitely used, but not as much. So we move towards a synthetic material. And the most synthetic material that we use is either a tiger mesh, which you hear about controversies about mesh, but it is a fully synthetic mesh. It does eventually reabsorb, but it takes a long time. And so over that period, your body's got to interact with it and not get problems. The other option we use is an acellular dermal matrix, which is becoming more and more common, and that's definitely what I use. And it's an animal skin, or it's an animal pericardium or something like this, part of a heart. They take all the animal cells out in the lab, and you're left with this kind of calcium scaffold that then your body grows into. And your body then grows into the scaffold, and it creates this kind of biological support that's all you eventually. So long story short, the supports we use eventually are part of you, and it's just the implant that's the foreign material. And so it goes either under the muscle, with the lower half then covered with the mesh, or in front of the muscle. And the subpectoral, prepectoral discussion on implants is like a massive topic. So I'm going to briefly kind of mention it. Under the muscle, the pectoral muscle, when you lift it up, it'll only cover half the implant. And to get the support in the lower half, you need to give it some cover in the lower half. So that's where you bring in the extra tissue that we stitch in, the pig tissue, the cow tissue. And that's alloderm. It's an American slide. Alloderm is like cadaveric human tissue. It's not used in Ireland, in case you write it down. And then prepectoral is the muscle. Here's the pink thing that's left behind, and the implant is then going directly into the pocket where it's supposed to be, where a breast is supposed to be. And this light blue thing around is your support, and it grows into it. And it does reasonably well. It's not perfect, but it's better, I think, personally, than moving your muscles around and having to deal with contracture and stuff. Prepectoral is by far and away less pain. All the studies show that. So you're much more comfortable. You don't get the twitching, you don't get the pain, you don't get the pull. You can switch from subpectoral to prepectoral. So if you have an implant in there, you can switch it out. It involves the risks of an operation and moving implants and implant infection, but it's possible to move it. And most people with prepectoral issues, it's all to do with the cosmetics of it. And so the cosmetics of a prepectoral are, well, I'll get to that. If you don't have enough skin, you can always do an expander reconstruction. An expander reconstruction is a way of stretching your skin to get extra skin. Same thing that happens in pregnancy. You stretch skin, you make skin. So you put in a collapsed implant, you slowly pump that up through a port in clinic where you put an injection in, maybe 100 mils every few weeks, and you slowly stretch that skin, the same way tummy stretches during pregnancy. And eventually you go on to get enough skin to create a breast shape, and you put an implant in underneath it. And it's a nice, slow, controlled way of doing a reconstruction, and you can get some really good results. And the reason there's an arrow here is this lady's had radiotherapy on the left. And so while most people who have had radiotherapy can't have implants afterwards because you get damaged skin, some people can. So it's always important just to consider it. But it's not perfect, right? So it's a good option because it gives you a reasonable shape size and you get out quickly and things like that. But it's not perfect. There's a big UK study that showed that 1 in 12 implant reconstructions fails at 30 days. And that is a massive statistic. And most units will say that they're better than that and things like that. But when they took all the units in the UK, they got to 1 in 12, which I think is completely damning. But at the end of the day, if you lose it, it's emotionally and psychologically problematic, but not physically problematic. They're not great at radiotherapy. Eventually, they'll need some sort of maintenance, implants switched out, you get contracture, you get some sort of issues. But that's kind of on your terms. So maybe it's 12 years' time. You'll come in for a general anesthetic day case procedure. If everything goes great, then you're done for another while. So while the theory of having to come back and do stuff is something that nobody likes the idea of, it's actually not the end of the world. I put up this picture because this is an implant reconstruction of mine, and on the face of it, when you look at it, you think, oh God, look at all the rippling, that's kind of terrible. But actually, I see this as a really good result so far. So she's had her nipples removed, so she's had nipple sacrificing. And if you look, I talk about this thing called, that I call the nipple to breast skin ratio. So her nipple to breast skin ratio, she's probably got a 6 centimeter nipple, and her whole breast tissue is probably about 20 centimeters. So maybe a third to a quarter of her breast skin is actually your nipple. So as soon as you take away the nipple, you change the shape of the breast. So it's physically impossible to get a symmetrical breast if you remove part of the envelope. It's just not possible. And so anytime you just have an implant-based reconstruction, losing a nipple, you'll change the shape. You have to, even if you have a perfect implant that goes in there. And you can do it in front of the mirror, like you just squeeze it and your breast shape changes. And I show it to most of my patients. But on this side, all I'm looking at is their lines. Yeah, I'm looking at this line here and that line here. They're really good. I'm looking at the cleavage, looks really good. I'm looking at this, it looks really good. And the dimpling, I see that as, and you go for a prepectoral result, it just happens. It's, that's because the mastectomy surgeons left me really thin skin flaps and there's nothing to hide it. And we're not under the muscles, so there's nothing to hide up there. It's super easy just to suck out a bit of fat and inject it. Sure, it's sore to get liposuction, as any of my patients here will tell you. It's sore getting liposuction injection, but you get a permanent result of permanent injections around it. Fat injection, I don't believe works for implants that have been irradiated. I'm a non-believer because I think you get way too much reabsorption and it's just probably not worth it. But in someone like this, there's no radiotherapy, she'll have a really good result from 1 or 2 rounds of fat grafting, and then it's a pretty long-term result. And this is without fat grafting, super simple reconstruction. Again, her breast shape changes, removing the nipple, but overall, she's a super comfortable reconstruction. Moving on to using your own tissue. A flap, and if you meet anyone with a DIEP flap, the idea of a flap is when you pick up tissue, you disconnect it and you put it in a different place. So you can do that anywhere in your body. And the classic one for the breast is you take tummy, you disconnect it and you put it in here. You can do thighs, you can do bum, you can do the love handles, but the most reproducible, reliable one is definitely the tummy. And the one that most people have a little bit of excess on is usually the tummy, which is usually why we use it. It's expected to be successful now. The tummy is like a 1 in 200 failure rate. Maybe, 1 in 100 is the classic thing we quote, but secretly we all presume and hope that we're down at 1 in 200. I can ignore that, sorry. And the idea with autologous is you can kind of shape and do whatever you want with your own tissue. You can try to shape it as best you can, whereas an implant, find there's like a couple of 100 different shapes of implants on a shelf. I see Healthcare 21 here, like your mind would boggle at the amount on the catalog and you're trying to pick shape, size, projection and things. But it can't mimic a breast. If you think about your breast in a bra, in no bra, and when you lie on your back, they're completely different shapes. It just cannot do it. Whereas your own tissue kind of can, kind of. There's loads of outcomes saying that long-term own tissue is better. And that's not in question and there's no discussion about that, okay? What is in discussion is it worth it to you, okay? An implant is free, it comes off the shelf. If you lose it, it's psychologically, emotionally troubling and it's upsetting and things like that. And you have to go to hospital, you get injection, antibiotics and things like that. It's all a nuisance. But at the end of the day, you haven't actually damaged part of your body or taken part of your body to make it. Whereas if you lose the DIEP flap and that doesn't work, that's a big sacrifice. You've decided I'm going to take some of me and I'm going to damage part of me to make a breast because my breast to me is more important than what my tummy looks like right now. Be that you could have a perfect tummy and still want to do it, or a tummy after 4 kids and 3 sections that you really don't like anymore. And so it's important to know that it's totally different for everyone. And so this lady, is there any downside here? If she doesn't mind the scar, if she accepts that she's got a scar straight across there, she's now implant free. She's got her own tissue up there. It's permanent reconstruction. She had a midline laparotomy surgical procedure there, a few kids and things. Always hated her tummy. So the benefit is different for everyone. And so the DIEP flap is something that, you have to just accept that it is different for everyone. And what people, the videos aren't playing. No, it's just I don't know, it's on that one. So it's basically, you take a lump of tissue from the tummy, is there any point in going through it? Okay, so I'll guess what way it's at. So basically you take a lump of tissue from the tummy, you open the muscle, you do not take muscle, it's just skin and fat. And then you plumb it into the chest. So you just connect up vessels in the chest. And while it's super simple, in theory, it gets a little bit complex. There's quite a lot of nuances to it. But at the end of the day, you're just stealing what you take off in a tummy tuck. And so the difference between a tummy tuck and a DIEP is someone comes into a cosmetic consultation and say, I would like you to take my tummy off and here's some money to take it off. In a DIEP, it's me saying, I'm going to take your tummy. And there's a bit of a nuance to that. Whereas if you come wanting to get rid of it, it's you actively asking for something. If I say I'm going to take your tummy, it's got to be give and take, that you understand that I'm, going to give you scars and things like that. I'm just going to switch to that. But the beauty of it is it's your own tissue and you can make it look really good and you can make it look natural. And that's a nipple sparing after we've taken out the little bits of skin, the scars have all settled down. This delayed reconstruction, you can get really good outcomes. We've added skin there. She hasn't had her nipple reconstruction, but you just get really super outcomes. And yeah, sure, it's not the same. You can't get back what you had, but you can certainly get really good, comfortable reconstructions. So it's a 1 in 200 rate of loss, which is not much. And so if you're prepared to use your tummy, most people can get over the 1 in 200. 1 in 20, 1 in 25 people go back to theatre. And if you go back to theatre, it's a nuisance, it's a problem, and it's super emotional and stressful for everyone involved. But rarely we end up in the 1 in 200. So most of the time we can fix. And then I generally talk about 1 in 2 complications. So like, you get wound issues and things like that. And most people just get one of these. Some people get hit with a couple. But at the end of the day, you do get over all of them. So I can fix everything except the 1 in 200, okay? But there's a bit of a journey there, and you got to be, you're signing yourself up to a pretty big thing. You can get partial flap loss, and I think that the more you do of these, the less you get. So I haven't really had any significant partials in a couple of years, and I think that's judgment calls. The recovery is definitely longer. An implant, they generally go home the next day. Yeah, they have their drains in their pockets, a bit of a nuisance, but they're up and at them, they're gone, and relatively back to normal life once the drains get pulled at 2 weeks. Whereas the DIEP is a journey. You're 4 days in hospital, you're another 10 days, I say, at home, I call it, recovery mode. You're just tipping about the house, driving around 3 weeks, and then back to normal activities from 6 to 8 weeks. But you're kind of wiped, so it takes a bit of time to pull back. You decompensate. You've been sitting on your bum for 2 weeks, so you kind of need time to build it back up again. And then the abdomen feels funny for like 12 to 18 months, but not funny enough to stop you doing your jobs and things like that. You get wound issues, we just tolerate them. It's part of the journey. Problem with DIEP flap is, how are we doing for time? How long more do I have? Okay, I have no idea. 11? Okay, perfect. The problem with DIEP flap is it takes a long time. There's not a huge amount of us doing a ton of them. And so like when you see in theatre, there's a load of us around the table and trying to get everyone around to do all that, it's just a little bit difficult. Whereas if you're having an implant-based reconstruction, it's a super easy decision. The implant surgeon's going to do the mastectomy, do the implant, you'll have a reg there. It's a smaller team and things like that. And so that's one of the barriers. Implants are fast. A lot of slim patients, really, it's probably the best and only option. Most slim patients, if they really want, can get own tissue reconstructions, but it's a big push. It's a bigger sacrifice. Fast recovery, no donor site, and I would guess it's an easier patient decision, okay? If you're like totally caught in a decision, there's nothing wrong with doing implants at the start and then having them in, and then in 2 years, you might be like, you know what, I freaking hate these things, I want to get rid of them, and then it's on your own terms. You've done that, they're not for you, and then you have to use your tummy, and then look, I'm not doing this, I'm going to use my tummy, and then there's no like regret, there's no like, I wonder, should I have done this? So oftentimes, if someone's really stuck, an implant is probably a better option. And then the expertise, which you talked about. So how do we refine that? How do we catch up with implants? Because I don't know if the slide is in here. The other thing that I say to a lot of my patients is surgeons are biased. We're like completely biased. Same as everyone's biased. You look at a picture of your kid and you think they're slightly better looking than all the other kids, yeah? It's complete bias. So I think I'm better at DIEPs, so I feel like I'm slightly better at DIEPs than everything else, right? So any person you meet, they will always give you a slightly biased opinion. When you meet me, most of the time I'll be honest, I'll say I'm biased towards your own tissue. But we're all giving you our opinion. We're based on our experience and based on everything we know. And so for me, it's all about trying to sell the DIEP as a better reconstruction and why make more patients to have it. So, we push hard to make the DIEP better. I mean, the standard operating time, like realistically in a delayed, should be 3 to 4 hours. So we should be horsing through pretty quick. And so it used to be like this whole mythical thing about 8 to 10 hours and a bilateral could be 12 hours. I don't know when the last, sure, I have bilaterals that go on till 8 hours. But I don't think I've had any recently that go on much longer than that. We've gotten much quicker. And we're doing things like anyone who goes for a DIEP, we scan you. And if you see my pointer here, why we scan you, see these white lines? So they're your perforators, the P of DIEP. That's the blood vessels coming through your muscle. These kind of oval things, they're your muscles. And so I can take a DIEP off this side on that blood vessel or one off this side. But with the scan, I can see this one runs through your muscle. That's going to be a pain in the backside to dissect out. And this one's running around the muscle. That's just going to pop out with no injury to your muscle, no extra dissection. And so if I have a scan, that's going to wipe an hour off the operation. And so that's one of the things that's changed things a lot. Refinements can we offer to everyone? Pretty much. I mean, there is a way to get own tissue for everyone. But you have to remember, someone who's slim likes their tummy. Yeah. So why are they going to give themselves a big scar here, a big scar here? When implants, a slim person usually has smaller breasts. Not always, but usually a smaller breast. And therefore, a small implant will be relatively manageable for them. And so that's why, it's not quite as common, but it's definitely doable. I use this patient a lot. She's I'd say she's like my 5th DIEP when I worked in London. And she had implants before, she somewhat deflated, and she was, I'm absolutely not having an implant. They're just not for me. So she had already crossed that threshold of understanding that she just didn't want an implant. And therefore, for her, as I can use your tummy, but you have a super tummy at the age of whatever, 50 something. And she's like, I don't really care. We'll do the scar. And I would argue that she's had maximal sacrifice. So this is before her nipple reconstruction, but you can see she's got a really good shape there. You can see a little bit of a tan line. She wears low-cut tops, and she, you know, it's a super good reconstruction. But I've definitely made her tummy worse, as opposed to other people I showed. I've definitely made the tummy better. And so personal sacrifice is, you know, a big part of it, especially in slim patients. You know, we do some refinements. You know, the drains are much less of an issue now. We generally quilt all our tummies down, or certainly I do, and other people are starting as well, whereby you're stitching loads on the inside. So if you think to make this tummy come down to here, I've got to dissect up under here, and therefore there's this free space, and that free space creates fluid. And we used to just stitch it down. The drain would stay, you know, a little bit longer and stuff. But by stitching it down, we usually get the drain out maybe day 3, day 4. Wound management, we use picos and things like this if needed. But wounds along the abdomen are still a bit of a stumbling block because they're always a bit slow. Long-acting nerve blocks and things like that. There's a nerve block agent that's not licensed in Ireland that will last for about 2 days. And we can't seem to get it through pharmacological reasons, but that's the next thing that'll probably come, that your local anesthetic will last you for 2 days. Your first 2 days in the abdomen are much better. And then a few other things. At the end of the day, we can always do a salvage. You can always come back with a bad implant and say, do you know what, this is terrible, this is uncomfortable, or I can't wear my tops, I can't, you know, half my wardrobe is in the wardrobe, I can't use it. And you can always swap it out using your tummy. And, you know, the projection and everything just gets much more natural. A nipple reconstruction or nipple sparing, you know, use the tummy. Again, that's a fairly slim person. And then sometimes you're forced to use your own tissue. So if you look at someone who's had radiotherapy after an implant, yeah, you have to take it out. Or sometimes you can take it out at the same time, put a DIEP flap in there. So there's always a bailout option in terms of this. Final thoughts is, like, literally every breast is different, as is every patient that walks into the room. And part of what I'm doing when I first meet you is trying to suss you out, as in what's your objective, who have you met? And most people ask, have you talked to anyone, or what do you do? And some people say, oh, I've read this, this, and this. And then I know which way I'm aiming and, you know, how to phrase it and stuff like that. But everyone's different. So what everyone wants is totally different. And so there isn't an answer. You know, that's why these seminars exist. And thanks to Marie Keating, because you're just trying to, you know, amass enough information. And it's particularly hard for the BRCA cohort because you don't have like a hot poker at your back telling you what to do. You don't have to, you're not being forced into making a decision within 3 weeks, because that's when your mastectomy is happening. You somehow have to like make a decision based on not having any personal experience, which is tough. Yeah, so the surgeons are biased. Yeah. My belief is that own tissue is your best option. But then again, you know, I've had a few patients and they've really struggled with the perioperative pathway and the postoperative pathway. And I guess I think there's definitely one patient that regrets doing it. I think I have 2 that regret doing it in, you know, hundreds. And I see that as a failure of my consent, as in I probably didn't tee them up enough to say how big a job they're going into. But it's pretty small too. But then I have lots of people who would meet me and I scare the hell out of them and they disappear. And for me that's great, because then they go away and then they come back thinking, okay, well, if all hell breaks loose, I'm kind of ready for it. And that's a much better patient, because then they can psychologically and emotionally kind of manage a problem. And then the objective in immediate, like if I meet you for an immediate reconstruction, the objective is that I can get you an almost completely disguised reconstruction, depending on if you have to lose skin or stuff like that. So that when in 3 years' time, when you're looking at yourself in the mirror, yeah, you'll have a scar, but the breast will be natural, normal, and should be pretty symmetrical. And in the delayed, the objective is, the phrase I use, you go to a hotel, you forget your swimsuit, and you just buy the one at reception, and that you can just put that on and not think about a padding or anything like that. And that's kind of where I try to get you in that. Yeah, I highlighted the biased. And that's it. This is best I can do in 30 minutes. You want me to? So I think there's going to be lunch
now. No, Q&A first. Yeah. So thank you so much. I think it's great to see your own tissue versus implant. And just to highlight that even though we're recording Jamie speaking, we're not recording the actual presentation, you know, sensitive images, GDPR, data protection, etc. So we have recordings of all this morning's speakers, which is brilliant, you know. So thank you so much, Jamie. I'm going to get some chairs up the front here, and we're going to get all the morning speakers up. So we've got Trina. Have we got Michael? Yep. What's wrong?
Face off.
Don't keep your face on there. How to give you. Yeah. So I guess before we get the speakers up, Jamie's going to introduce or tell you all what's happening in the Sarsfield room, as in the show and tell. So
Yeah,
yeah.
I guess it's some are patients that have been with me, some are not. And the point is they've very kindly agreed to come in. They've been through the journey, and so they're probably not, they wouldn't have come today other than this. They've been through the journey and they're happy to share. And I guess how I decided was random, who came to mind, but the people who usually come to mind are the people you think are have had a standard pathway, as in hopefully not a perfect pathway, and people that are generally, happy people that are happy to talk about it. And so there's a range of different people that are in this group, and everyone's had a different pathway. I won't tell you what their pathway was, but just to say thank you to my 3 patients who've come in, and obviously the other 2 as well. But I kind of felt bad asking them. But then the response is like, oh, yeah, okay, sure. So most people are kind of happy, and sometimes it just helps to see. So how it works is, I think, we're going to congregate somewhere over there.
I think there has been a sign-up process for this, but there is still some spaces available. So if there's anybody here that wants to go and see those lovely ladies that have had either implant or DIEP procedure, it's in the Sarsfield room. So if you go out to the front to reception, Sarsfield room is right beside reception. And we are saying 10 minutes max with each of the ladies. It's an amazing thing to do. We do not want to exhaust them. But they're very kind to do this. So yeah, there's a golden opportunity. For everybody else, we're going to have Q&A. So we're going to have, Jamie's going to hang on for Q&A. And Trina and Michael and Dr. Omar had to leave, and Samantha. So I'm going to get some high stools up here, some water, I think, as well.
Yeah, last thing I would say is if you have a surgeon, most surgeons will connect you to another patient. And I try to match someone in similar location to similar reconstruction stuff. It's kind of hard to kind of remember people. I should do a better database, but most surgeons be happy if you ask them, or ask their secretary, is there someone I can talk to? Or breast care nurses generally have a list of people who are good to meet with. Yeah.
Thanks, Emil. I'm going to pop you up now in the front here. So let's get the microphone. I think it's on the table. No, I think it's nice to be on there. I think when you're low down, nobody can see you. Yeah, there we go. I'm sure it's working. I have the sound. Do you have to work them? So while we're getting the microphone sorted, I think have we got another roaming mic? Was there the roaming mic down there? So has anybody got any questions for Samantha, for Jamie, for Trina, for Michael, anything related to this morning? I don't know. Yeah. No, you hang on to that. I have to turn it on and around. Is it working now?
I think so, yeah.
Yeah. Hi, just a question for Samantha, just around the diet stuff that was really good. What about, is there any consideration around, I don't know what it's called, but some test you can do about the individual and how they absorb nutrients, and the time of day that you eat, is there any consideration there? You could be eating all the right stuff, but how you as a person individually absorb it, is there anything else you could be doing additional, or any kind of tests that you get done to do that?
Oh, sorry.
No.
It is on. Okay. Thank you for your question. No is the answer. There is no test that you're missing that's going to help identify what you're absorbing. We don't do standardized blood tests, even routine blood tests, to look for nutrient deficiencies unless you have symptoms of a deficiency. And the only deficiency that would be really important for people with BRCA to get a blood test for, possibly, would be vitamin D. But we don't test for that, and all the GPs around the country will hate me for even suggesting this if you all start going looking for vitamin D tests, because it's not routinely tested, the expense, there's so many other factors with it. So we actually advocate that you take a vitamin D supplement. But no, there's no test to see what you're absorbing from nutrients.
And what about the time of day that you eat? Should that be?
Oh, that's there's no set guidelines on time of day to eat. Is that kind of referring to intermittent fasting?
No, it's just something I was chatting to a friend about that, or actually even, there's a masseuse that I go to actually, and she was actively trying to have her dinner with our term dinner in the middle of the day, because she was kind of saying by eating at night, she wasn't absorbing the nutrients, there wasn't enough time in the day. I don't know, like she was actively having her bigger meal between 12 and 2 and something smaller in the evening, because she felt that was absorbing the nutrients.
There's no research to suggest that at all. That might be a personal preference, just to have the bigger meal in the middle of the day. But from an absorption point of view, no.
Right,
And
thank
sorry
you.
for being so blunt,
No,
but like,
that's-
yeah,
I
I'm
love
going to
it.
keep my answer short because I went too long.
Appreciate it. Yeah,
Okay,
thank you
yeah.
very much.
Hi, I'm just wondering about the Mediterranean diet and food intolerances. Like I have a dairy intolerance, egg intolerance, and gluten intolerance. Now I still eat the foods, but I just can't eat them regularly. Is it easy to follow the Mediterranean diet with those?
Yeah, most definitely. So you said dairy intolerance, and what was
Yeah,
and what was
dairy,
it?
eggs, and gluten.
Okay, so Mediterranean style diet is perfect for all of the above. So where you'll get your calcium sources will be from dark green leafy veg, but you can also get calcium from fortified soya products. If you like soya products, you will get calcium from them, and it will be a good replacement if you have problems with dairy. Now, again, if it's from a dairy point of view, is it lactose? If it's a lactose issue, you can get lactose-free milk. Cheese is very low in lactose, so you'll still get your calcium from those sources. And you can definitely have, if you want, for whatever reasons, have your gluten-free options. They're all part of Mediterranean style diet. Eggs, you will have other, like what's a replacement for eggs or other protein sources. So the Mediterranean style diet advocates for at least 3 portions of fish per week. At least 2 of those should be oily, something like salmon, mackerel, trout, if you like those sort of foods. You'll get protein from pulses, chickpeas, lentils, kidney beans as well. So you won't be at any detriment from following a Mediterranean style diet while not having gluten, dairy, or eggs.
Okay,
Yeah.
I just wanted to. That's
Oh, you can totally adapt it. Yeah,
yeah, brilliant. Okay, thanks very much.
no problem.
Just another question on nutrition. I'm just wondering what the current stance is on phytoestrogens for for estrogen positive breast cancer patients.
Yeah, that's a great question. We actually have a full section as well in our free resource on this topic. So there's a lot of, I suppose, there's scaremongering sometimes with soya products because they contain phytoestrogens, and because estrogen's in the title, a lot of people think it's the exact same as the estrogen that's in your body, especially if you've had an estrogen positive cancer. Soya is actually quite safe for people who've had breast cancer. There's actually recommendations that have just come out around the amount of phytoestrogens to have per day. We don't eat anywhere near the recommendation for phytoestrogens in an Irish diet. So what we advocate with phytoestrogens is in food form, it's safe. So if you're getting your phytoestrogens, which you get from the likes of your pulses, your chickpeas, your lentils, but as well from soya products, that's safe. We don't advocate that you go for an isoflavoin or a phytoestrogen supplement because they're very concentrated sources of phytoestrogens and they're not tested. So we don't know how they work in the body. We don't know how they interact with tamoxifen, for example. But phytoestrogens are safe for breast cancer survivors, for people with cancer, for people trying to prevent cancer. They're perfectly safe. And you can use phytoestrogens as part of your diet. Like if you want to have soy in the diet, that's perfectly fine. Tofu, fermented soy, all those sort of things, they're perfectly fine and safe.
Hi there, a question from Mr. Martin Smith. I had seen an article in the BBC, and apparently a team of surgeons in London have done the first in the UK DIEP with using keyhole surgery on the stomach. And I was just wondering if that's something we can hopefully see in Ireland in the near future.
So the issue is so what they've done and what you're talking about, so the Simani robot is, yeah, there's loads of things, right? But at the end of the day, you need to make the cut because you need that skin and fat. And if you take just the fat, you'll have a load of excess skin that kind of hangs down and looks really cosmetically poor. So there's no role for minimal access incisions in DIEP flap surgery, like zero role. So the robot or the minimal access stuff is going through the muscle or going through the outer sort of core of your tummy to dissect the blood vessel out through the muscle. And so that's what you're using robot for, or the laparoscopic or keyhole incisions. So yeah, it might reduce the incisions on your muscle, but there's other ways of doing it. So there's a big body of evidence against trying to do it because it actually doesn't change anything. What's coming is hopefully, so the Marsden where I used to work is doing robotic microsurgery, which means you can do much smaller vessels. And the theory of that is then that you don't even need to go down through the muscle, that you just take maybe 2 centimeters of blood vessel as opposed to me chasing it down for 10 centimeters. Then you just connect that tiny little thing onto something in the breast. Because we have blood vessels everywhere, but what we do in DIEP surgery is getting a big blood vessel, relatively big, to connect to another big blood vessel. So what's maybe in the future is that, you know, it's called perforator microsurgery. So we're connecting just fat with a tiny bit of blood vessel onto one of your other blood vessels in the breast, and therefore we don't violate your muscle in the breast or in the tummy, and that's probably like the next level of stuff.
My question is also for Jamie. I had a DIEP surgery 2 years ago now, and I had skin necrosis as a result of it. So the scars are still quite bad, thick, hard. And I also have like a rippling kind of thing that was due to fluid afterwards as well. I've been discharged now from plastics, and I'm not sure, you said that anything apart from the 1 in 200 can be fixed. At what point do you say this is as good as it gets? Or
yeah, I mean, it's a good point. And maybe, you know, as long as so your scars can't be fixed. And if you do have a bad scar, there's always scar, like it's impossible to discuss like a personal thing, but like I pretty much don't discharge anyone that's not right. I mean, very odd time, yes, I would get someone with bad, maybe fat necrosis or a partial flap failure, which I mentioned, that, you know, you can't fix it. You've got to go down and take down that reconstruction, put another reconstruction in. Like a fluid thing, that I guess hard to comment. But most things, as long as I've consented for someone for scars and a bit of slow wound healing and a poor scar in the middle, even if I get some wound necrosis here on the abdomen, the abdomen or the breast, you can just excise that and re-stitch it again. You still have the scar and you can't correct that scar, but you can improve the scar. On the breast, if you get a lot of breast skin necrosis, which is the classic one, I guess that's not, you know, that's the divide between us and the breast surgeons. Whatever way they've done the mastectomy, some of their breast skin divided, and the bigger the breast, the higher chance of breast necrosis. And as part of my consent, I'll say that, but I don't control that, and I can't fix that. But it's not the DIEP flap that generally is failing. Yes, the partial DIEP failure is my problem, or not my problem, or something I have to try and fix. I can't, if your mastectomy has killed some of the breast skin, that is just the result of your mastectomy. But yeah, maybe it's a little bit blasé of me to say I can fix everything other than that. Yeah, I take that point on board in that. Yeah, there's what I see as a good outcome may not be what someone else sees as a good outcome. But most of the time, what I see as a good outcome is way better than a lot of other stuff that comes through. But it's everyone's different, and what you might expect or the results you might get may be nowhere near what you were hoping you were getting. Maybe not what I kind of sold as well. So that's part of the problem with the consent process and stuff, and making sure they're on the same page. And part of what I said is that I've got to try and figure someone out and see what they're expecting. But yeah, if it is breast skin necrosis we're talking about, that is not something I can change. It's not part of the reconstruction. I'm using some of your breast skin. And if I haven't got good breast skin, yeah, there's different things I can do, like we can delay the inset and steal more skin from the tummy and things like that. But at the end of the day, it does, you know, mean you're using more tummy skin to reconstruct, and then you head more towards a delayed picture. So yeah, maybe noted. Can't fix everything.
Hi, I just want to know if there are any complications. Sorry, it's kind of a general question for anyone who wants to jump in. Any risks or complications around bilateral mastectomy for recently diagnosed diabetes 1, and length of surgery times, etc. And then if there's anything from a dietary perspective. So just 4 months.
From my point of view, there's a load of evidence, mainly from cardiac surgery, looking at type 1 diabetes, that's if it's super well controlled, HbA1c is really good, that your risk of complications is a little bit higher, but not massively higher. So it wouldn't change my decision making. And I don't think change yours.
Dietary point of view, to stick, if you've seen a dietitian for the type 1 diabetes, to stick to the dietary advice if it's carb counting with the insulin. The only thing you might find is that sometimes wound healing can be an issue in type 1 diabetics if it's uncontrolled high blood sugars. That's the only thing I've seen in practice.
So, sorry, just coming back, would you recommend waiting? I'm only 4 months diagnosed.
Pardon?
From a surgery perspective, would you recommend waiting then
It's impossible
to tell?
not go too deep, but most people on type 1 diabetes, most people are monitoring their sugars like unbelievably closely. So our sugars are super well controlled now. We've so much tech that I don't see any point in, like, I don't think the diabetes should lead the discussion.
Okay, thank you.
Would be my thought.
Hi, this is a question just for Dr. Martin Smith. I'm undergoing the implant expander surgery in July, and I just wondered how long the expanding of the skin takes. It's a really straightforward question. I probably should have asked my surgeon, but
Yeah, I mean, so it depends if you've had radiotherapy or no radiotherapy. Honestly, if I put an expander in, I generally expand maybe every month, a certain amount. You generally overexpand, so you make that side a bit bigger, so you get extra skin, because as soon as you take the expander out, it collapses a bit. And then I generally tell people, I like to leave it just for ages, maybe 6 months or so before you exchange for an implant. Okay. And then once you do that, it depends if you're pre or subpectoral. I would usually then bring you back maybe 6 months later for injections of fat around it as well. Okay. But I mean, it's waiting list dependent as well. So yeah, that's the bigger issue is how long does the waiting list or whatever access you have, how long is that going to take to get you back in? But I tell patients there's no rush on it. It feels a bit different because it sloshes a bit and it's not quite as solid as an implant. But at the end of the day, it gives you a relative idea of what you're going to have. And the longer you leave it, the better the pocket forms. And the more you can see it drop and stretch a little bit, the more the surgeon gets to see when they bring you in is where do they need to release a bit of scar, where do they need to expand the pocket to make the implant sit maybe more medial or more lateral. So the more mature it gets, the actual nicer picture you get. So even with my DIEPs, when I bring them back, I generally try to delay a little bit, because the more mature they become, the more you see the inaccuracies that you can try and fix.
Great, thanks.
To go ahead? Yeah. Hi, this is for Michael and Caitríona. I'm just wondering, in the kind of medium to long term, how assertive do you anticipate the surveillance program being, in terms of being kind of centrally managed, people being notified? I mean, all the women here are clearly able to advocate for themselves, but I'm thinking of other women who may be BRCA positive, who perhaps for whatever reason don't have the kind of the wherewithal to be tracking down, nagging their GPs for appointments. In other words, is it going to be proactive? Is it going to be like a screening procedure?
Thanks for the question. I think the benefit of the testing is that it's empowering knowledge, in that for the most part, the patient, particularly the women who are BRCA positive, it does empower them because they know at the very least they need a mammogram and an MRI every 6 months, say from 25 to 30. So their patients are usually very good to follow up if the appointment doesn't come in to see whoever their specialist is. They're very quick to pick up the phone and ring the consultant secretary and say, by the way, I'm due an appointment. Where is it? So they're usually the testing does help prioritize patients in terms of who has a clinical need for services, and certainly the services are there in the large tertiary centres like St. Vincent's, St. James's, Beaumont, and in Cork as well. The larger centres have the high-risk breast screening services, and of course they have access as well to the genetic services if there is an issue with their follow-up. So the services are there, and usually as part of the genetic counselling process, patients are aware of the pathways that they should be on, and they're typically are referred on once they get the result if they're BRCA 1 or 2 positive.
Thank you.
Yeah, just to add to that, I suppose it is an issue in terms of needing to better structure the system, though, because, to make sure it's not all dependent on the patient remembering. And definitely those resources we talked about, the genetics resource associates, for example, that when I talk about the admin side, it's not just your referral, say, to a genetic counsellor, it's also all of that. If you're not having your prophylactic breast surgery, for example, you could have years and years of MRIs. So there is definitely sort of a move to have that, maybe not as something like a national breast check program, but at least within your region, that there would be systems to both coordinate that for patients and track it, but also to make sure that enough resources are put in there, because that's a really big challenge. I'm sure there's people in the room who've come across that, where a lot of the demand for scans and imaging within a hospital, that might be prioritized for people who are presenting with symptoms. But actually over here, you've people who actually know that they're at high risk of breast cancer and are meant to be getting this test every year, for example. So, how to make sure that that is protected for patients, that it's not just about waiting for a cancer to occur and treat it quickly, but keep an eye on the people. So absolutely, there's both in terms of, I think, almost like the IT systems and the and the resources, but also, sorry, one more point on that is it has been flagged, just to make sure that we don't kind of put people into a surveillance system that doesn't have all of the other things that people need with BRCA. So, that the actual, say, your ANP-led service and the holistic care of an individual, and including watching out for ovarian cancer and making sure there's a plan in terms of that surgery, but also if you're looking at chemo prevention, or if there are issues around supporting with contacting family, or the managing a surgical menopause. There's so many other things in care that it doesn't just become you go on this list and you get called for your test every year, that the rest of the care is put in place too.
Take about 2 more questions. Is that okay?
Hi, I'd just like to thank all the speakers for, there was such informative, such energetic presentations, and also the organisers. Just a couple of comments in terms of the changing landscape as well. It does seem to be changing all the time. I mean, I already noticed, Caitríona, you mentioned separate access now to theatre coming online, and I've kind of noticed that in Cork even over the last few months. But also, Michael, you mentioned the change of approach potentially to oophorectomy now that they're going to be starting looking at going with the fallopian tubes first. And I think there's a clinical trial in Cork. I didn't pay much attention to it because I'm too old for it. But just thinking about that in terms of the future and for younger women, what kind of timeline is there any way of predicting the timeline on changes there? Thanks.
I would hope that some data would be available soon, but I don't think it's standard of care just at the moment. But certainly it's optimistic for patients, because obviously, small children, busy careers, thanks very much, I'll be menopausal in my early 40s, that does impact on quality of life. So we're awaiting the follow-up results with interest, obviously, because I think it will have a huge impact potentially on the care of women who carry BRCA1 or 2 mutations. So I'm sorry, the data just isn't there yet, but hopefully within the next couple of years we will see what the outcome of those studies are. Because I know there's one in Canada and certainly in the Netherlands looking at this particular question, and others too, as you mentioned.
I think on that, the Protector study that was looking at that as well, which was UK and international, that closed in December. So the outcome, we're waiting, and hopefully soon here. It was a huge study looking at exactly, saving the ovaries and removing the fallopian tubes, and then removal of the ovaries at what would be the normal age of menopause. So we should be hearing the results of that soon, because the study is now closed. So we take 2 more questions. Is that okay?
Hi, I just wanted to ask, for risk-reducing surgery, there's no surveillance really after that. It's kind of like I'm 12 years out from DIEP surgery, and also I had my ovaries and fallopian tubes removed as well. And I haven't had one appointment or anything. I don't want an appointment after, but I just wondered, in general, is there a surveillance? Because I said it is risk-reducing surgery, but it's not eliminating the risk. And I just wondered, is there anything in the pipeline for any age, really?
I guess I'm not the one. I don't know, does anyone actually? So most patients will have some sort of informal agreement with their local units But in theory, your risk is then lower. Like I'm obviously the reconstructive side, so I don't have this discussion, but in theory, your risk is lower than the general population because you're 99%, or 98% of tissue is removed. And so you should really only have a long-term relationship with someone if there's if you're a high risk or whatever. So I guess probably no, but I don't know that as a guarantee. Yeah.
Oh, thank you. Yeah, because the risk reducing surgery reduces your risk by 90 to 95%. So by performing a breast exam, if you notice any changes, so I know we would discharge our patients maybe 18 to 24 months. But if you notice a change, you can just you should be able to contact your center and get looked at. Like there's no evidence for mammo or MRI.
Thank you. That's great news. Thank you very much.
Carol Spillane here, advanced nurse practitioner. One more question, Michelle?
This is a question for probably Michael. My own self, I'm a BRCA1 carrier with very strong ovarian history, family history, and no breast. So I'm finding it difficult to make the decision to move on to prophylactic breast surgery now as a result. I'm just wondering what the level of research being done on the variants within the genes themselves.
Well, in terms of ovarian risk management, I mean, for years, we were, with Professor Daly in St. James, we were referring women who were BRCA1 or BRCA2 positive for transvaginal ultrasounds and CA125s every 6 months. But the data suggests ovarian screening detects ovarian cancer, but not at an early stage that makes any difference in outcome. So most of the gynecologists now are saying if a woman's risk is significantly higher over lifetime, then the decision really comes down to timing of risk-reducing oophorectomy. Now, in some cases, I mean, I have come across a couple of women who carry BRCA genes in their early 40s, and they're not sure if they're finished family. So for those women, consideration of ovarian screening mightn't be an unreasonable thing to consider, but to be mindful of the limitations.
No, sorry, Michael, it's more that I've had my own hysterectomy, but it'd be like, I know I'm a BRCA1 carrier, I'm at risk of breast cancer, but when there's no breast history at all in the family, I thought I stumbled across some research recently on actual the variants within the genes themselves, that some are higher risk.
It's a very difficult question to answer because the majority of the studies, they look at all types of mutations. So you're looking at deletions, duplications. It's a really difficult question to answer because as I said this morning, like we do meet women in their 70s and 80s who carry BRCA genes and don't ever develop cancer. So it's a very difficult question to answer. I don't think the answer, the data is there yet, and it probably won't be there for a significant number of time because all the studies look at all the various types of mutations that occur within both genes.
Yeah, just Magella Hickey's my name, and I'm a peer-to-peer support volunteer with Marie Keating. So just two things. I liked, Jamie, the way you emphasised the importance of patient choice, because I suppose when I was going through it, I definitely experienced the surgical bias. So the oncosurgeon was very neutral, but when I went into the plastic surgeon in another hospital, he was like, I'm biased towards the silicone implants, but he said, I'm very happy for you to explore the DIEP flap. And he said, if you would like that, we can link up with Beaumont Hospital and you can have that. So I liked that I had choice, even though he said that that wasn't his surgery of preference. The other thing I suppose that I got from that was my plastic surgeon, put me in touch with two people, one who had DIEP flap and one who had silicone. I found that really helpful because they did a show and tell. I think it's really great today that Marie Keating have provided us with this opportunity that we can go in and have a look, because when you look at the stuff on the internet or even there, it's better to meet someone who's, you can actually see it and feel it or whatever, you know, so I think that's really helpful. And then just yourself, Samantha, I went through, when you were given that presentation, I did everything that you presented there. I went on supplements, I did exercise. Before my my mastectomy, I got a fitness coach who did weightlifting with me. I got new programs all the time. And then just after my mastectomy, 4 weeks later, I did the 100 kilometers in 30 days with Marie Keating. And everybody was out on the road beeping at me going, what is she doing? She's just come out of surgery. And it wasn't easy to build back up the energy. But by God, from the time I got my first surgery to the end, I have never had fatigue issues. And even when I was in Vincent's hospital having my chemo, I remember asking the nurse, can I have the results of my bloods? And they were like, what do you want them for? And I said, I want them because I want to see is the magnesium levels dropping or staying the same. And they did drop in session 2 and session 3. So I went on that magnesium glycinate. And by the time I was finished, it was back up at 83. It was 85 before I started chemo, got it to 83. And I never had fatigue issues. And I'm not saying everyone is different, and I don't want to compare myself to anybody else, but I did all that stuff, and it really, really paid off. So I suppose I missed the first 2 speakers because I was late, so I can't ask you a question. But just what I would say is knowledge is power. And there's experts there, but we are also experts by experience, and not to underestimate what other people have gone through. And just my final question, Samantha, you mentioned at the beginning the name of a book that you'd written. What was the name of that book?
I have it with me. It's called Menopause, Diet and Cancer. It's going to be on the Irish Cancer Society website. It's free.
Okay. Brilliant.
Yeah, thank you.
Brilliant. Thank you so much.
It's free. So
it's free. Okay,
yeah,
brilliant.
You don't have to have cancer to follow any of the advice in it. It's
Brilliant.
perfectly safe.
Thank you so much.
No problem.
Thank you, Magella. That's a nice way to end. And Magella will be back on the stage afterwards. So thank you so much to our excellent morning speakers, taking time out of their busy day to be here. Without yourselves, the audience, without our speakers, and without our sponsors, we wouldn't have an event like this. So I just